बंधु वाला नहीं था.
So Rupesh and Anupama are third. And who is introducing them?
Dr. Meenal is introducing me. That she called me up today morning.
अरे मीनल बोलो ना यार.
Where is Meenal?
कुछ disturbance नहीं कर रहे.
But Meenal was there. She called me up.
And last is Rupa.
Same
Where is
here.
Rupa?
बस हो गया. Okay.
स्वरूप.
हाँ.
रूपाल जरा फोन कर. आणि Dr. Vaishali Kale, you are going to introduce
Rupa madam.
Rupa madam. That's right. That is the sequence.
Yes.
After the
इंट्रोड्यूस करायचंय, राइट? हेलो मैडम, आप लॉग इन कीजिए ना. Yeah, you are there now. We have started already. The panelists have logged in. We are supposed to log at 3:30. अभी हो गया log in. अभी delegates भी log in करेंगे. January and all the participants have to put their photograph. Yeah, Rupesh, तुमचा पण फोटो येऊ दे.
Okay, sir.
Yes, where to put for our pic?
कळत नाही काय फाईल तर घ्यायचं. मी मिनिंगची घेतली मी 7व्या महिन्यात. मला काय त्याला माहित नव्हतं. घेतो. अमितला बोला ना. अमितला लंच झाला असेल.
जान्हवी विनीता, तुझ्या लॅपटॉपचा जर अँगल थोडा चेंज कर.
एक मिनिट.
Now you are seen properly. Yes, that's good. Anupama, you also do the same thing.
आपला फोटो ठेवायचा आहे काय? म्हणजे आता कसा ठेवायचा फोटो?
Video, you should be visible. Either a photo or your video. Current आम्ही याचे snapshots घेणार आहोत ना, screenshots. Yes, this way. Your face has to be visible.
Sir, attendees cannot start their mic and video, so their video and mic will be disabled.
Video on रहने दो.
व्हिडिओ ऑन पाहिजे ना त्यांचा.
Video on पाहिजे.
No, sir, we are using a webinar platform. So what happens in this platform is attendees are in a different section. So as you can, if you see in the participants.
नाही. For MMC purpose, we have to take their photographs. Screen वर दिसले पाहिजेत.
No, sir. Usually we don't do this for म्हणजे
नाही, पण ते आम्हाला काल रायटिंग मध्ये इन्स्ट्रक्शन्स आले आहेत. आपण हे स्क्रीनवर येतो ना, तसं त्याचे स्नॅपशॉट्स.
Okay, but we can see their names.
Snapshot यायला पाहिजे with the photo.
नाव आणि त्याची MMC नंबर पण दिसले पाहिजेत.
Okay, but we can also do one thing. At the end of this webinar, we can generate a Zoom report. त्यामध्ये तुम्हाला डिटेल्ड मध्ये अटेंडन्स दिसेल सगळ्या पार्टिसिपंट्सची.
नाही, अटेंडन्स पाहिजे, पण MMC also requires a photograph with the name displayed under the photo. So we have to take a screenshot of all these delegates every half an hour or every 1 hour. What MMC has recommended is half an hour after the CME starts and half an hour before the CME ends. We have to take screenshots of all the delegates with which their face has to be seen with the name and MMC number in their display, so that it is easy to identify them, and that is how MMC will mark the attendance and will give the permission to issue the certificates. So only the people whose face with the name and MMC number is seen, only they will be granted the attendance.
Okay, sir, but I wasn't aware of this thing. I wasn't told. And in this webinar platform, we cannot do so. We cannot start the attendees video actually.
Not video, this is a snapshot. We want a screenshot of this.
So webinar doesn't allow attendee to be seen.
Yes.
Webinar has two phases. One phase for the
आदित्य आपल्याला किमान सुरुवातीच्या सगळ्या लोकांचा फोटोग्राफ चालू करून आणखी शेवटचा एवढा तरी मिनिमम द्यावाच लागेल त्यांना. लोक आहेत की नाही कसं साध्य सिद्ध करणार तुम्ही?
सर युजली कसं होतं MMC क्रेडिट्स यासाठी या अगोदर
नाही तुम्ही ठीक आहे तुम्ही आता तुम्ही म्हणताय ते पण तुम्ही चेंज काय करू शकताय ते मला सांगा ना.
सर राईट नाव वी कॅनॉट चेंज.
मी तर सर तुम्हाला सांगितलं होतं ना मी माझ्या नियमामध्ये पण आहे व्हिडिओ हॅज टू बी ऑन.
But that is what we were told. In fact, I even have it in writing from them, and even on a telephonic call, they had told me the same, instructed me that we have to take half an hour after the CME begins and half an hour before the CME ends. We have to take a screenshot of all the delegates, and we have to cut, copy, paste each and everyone's photo with their name and submit it to MMC. How have you guys done in the past with MMC?
Sir, in the past we have we used to share the screenshot with the names of participants, and we used to share the Zoom report.
Just a moment.
IMT याला कसं केलं होतं?
We cannot see the delegates at all, okay, in this? In the Zoom call?
I think one thing we can do, if it is possible, I don't know, we can ask every person to keep their photo as a profile photo for Zoom. So in the list of attendee, that photo can be seen. If you click on the participant list, that photo can be seen there against their name. But then I think we have to ask to everyone to keep that thing.
Now how to add
Now Sarup, hello. Now in this situation, what we will do is participantच्या लिस्ट आपल्याला स्क्रीनशॉट मिळणार आहे. पार्टिसिपंटच्या लिस्ट ह्याच्यामध्ये तुम्ही तुमचा प्रोफाईल फोटो ऍड करा. थोडं सांगा. आलं का लक्षात? म्हणजे त्यांचा फोटो तिथे ऍड होऊन जाईल. दॅट इज मोर दॅन सफिशियंट. कोणाचा व्हिडिओ चालणार नाही आता. ऍट द 11th hour वी कॅनॉट चेंज द टेक्नॉलॉजी. ठीक आहे.
प्रत्येकाला लिव्ह करायला सांगावं लागेल. पुन्हा त्यांना झूमच्या प्रोफाईल फोटो मध्ये त्यांचा फोटो लावावा लागेल आणि ते पुन्हा जेव्हा ऍड होतील म्हणजे वेबिनार मध्ये जॉईन होतील तेव्हा तो दिसेल फोटो.
मग तसं करायला लागेल. तो फोटो कुठून आणणार ते?
प्रोफाईल फोटो त्यांच्याकडे स्वतःचा एखादा फोटो असेलच की प्रत्येकाकडे.
करायचं का मग तसं?
हॅलो. There are 143 participants, 144 now.
Sir, I request everyone.
Participants 145 and attendees 128 finalists हो हैं.
Sir, I request कि other devices जो है आपके सबके बंद रखिए, नहीं तो इको आएगा.
Yeah.
I think we can start whenever you are ready.
Those who raise the hand. Hello. Start. Unmute. Sarup, unmute.
Good evening, all. Welcome to the first webinar of TPA for the year 2021. This is the first one. Hopefully, we'll have a lot more this year after a bad last year when we couldn't meet at all. So I hope we are starting on a good note with a very interesting webinar and a CME lined up for all the participants. First of all, I would like to tell everybody to have a profile pic on display so that when the time comes to submit the attendance, we have your photograph and your name and the MMC number on display below your photo. So kindly do that. You have the next 3-4 hours to do it. But I request all the participants to have a display photo with their name and MMC number properly displayed, because we will require it when we submit the attendance to MMC. I now welcome Dr. Shraddha to take this meeting forward.
Thank you, Dr. Swarup sir. Good evening all, and I hope you all are safe and keeping well in this COVID situation. So it's like I am very lucky to have this opportunity of introducing our chairperson and observer, Dr. Dinkar Desai sir. As we all know, I don't need to introduce him, but to start with academically, sir has done MBBS, DCP and MD. In addition, he has done RIA from BARC. He has 5 years of teaching experience in Miraj Medical and 35 years of private lab practice. In addition, he has done LLB with diploma in cyber law. Also done PG diploma in hospital management. So in short, our president is unique person with mastery in medicine, law and management. He is recipient of Thane Gaurav 2007 as well as 2018, plus Thane Gunijan 2005 awards. Also an expertise in chess with international FIDE rating in registration and rapid chess. As we all aware, he is current president of Thane Pathology Association. In addition to that, he is convener of Jan Raksha at Thane.com, as well as he was ex-vice president of IMA that is Indian Medical Association Maharashtra, as well as ex-president of Indian Medical Association Thane and ex-joint secretary of Indian Association Medical twice in Maharashtra. Apart from his academic excellence in current cultural field also, he has won many prizes, such as in debate, Kathavanchan, Kavyavanchan, and drama for writing as a writer, director, and action. He is columnist in many newspapers like Dainik Padhari, weekly article for almost 10 years. Also writes poems and articles in newspapers and organized many cultural and musical events. So I welcome Dr. Dinkar Desai sir to chair the session, today's TPA, the first CME, and also as an observer of this CME. Welcome, sir.
Thank you, Shraddha, for so nice words. I welcome you all on behalf of the Pathologist Association, that is TPA, and wish you a very happy new year. I know this is a very different mode of meeting, and we are not used to it, and rather we do not like. That is why we postponed for last 9 months. But now there is enough pressure on us as organizers that you should have something for giving CME points, MMC points, because we are short of that and we need from our own subject. So with a lot of difficulties, we have accepted this online webinar thing. In a way, it is very good that you don't require to go to a single place from all over Maharashtra, here and there. You don't require to spend much time in the given stipulated 4 hours. You can finish the things and you can check up and do your normal duties, so you don't miss anything in your day-to-day practice also. Of course, people will say that nothing is left in the practice, so what is going to be missed? That is a different story. But the real problem of this online webinar, which we always know, is eye-to-eye contact, where the audience and the speakers, the faculties, they cannot meet each other, and they cannot have interaction. And that is the only missing thing in the online webinar. Almost 300 and more number of people have registered, and I see at present 176 participants, and there are some 15 panelists. So we are touching to a number of 200 at this time. Slowly the number will increase. Most important thing is, Sarup, you have not read the rules. Would you like to? You have got the rules. Be prepared for that afterwards. And these rules are very important. You cannot leave the meeting. If at all you want to leave the meeting, leave it now, and come with another registration and add your profile photo. That is a very important thing. You can add your photograph right now also, but if you are unable to do that, you can leave the meeting and rejoin the meeting. So that is the thing. Because for MMC purpose, the list of participants must be seen. You must be seen at all times. So at random, we will be having 8 shots of the participants. In the chat box, you can put your queries and inform us that you want to discuss on this point. Whenever time is possible, we will definitely invite you. At very right moment, I thought we will be able to see each other, but I am nervous here that this is now a different webinar mode and not meeting mode, and because of that, only panelists I can see the faces. So there will be definitely some difficulties in this because this technology is new to us. So many of us are not aware how to join a Zoom meeting, how to participate on online webinar. Things will smoothen in due course of time. It will take some time. And I welcome all the faculties and speakers who have come here. I am also observer, so my job is dual, one of organizer and another is of observer. So I have to be liberal on observer. I have to be liberal on organizer front, but I have to be very strict on observer front because I am representative of MMC also. So on 10th January, we are having another session. What we are planning is we will be having 2 CMEs this month. So 2 points will be there. We will be having 2 CMEs in the next month. So another 2 points will be there. And in the month of March, there will be, we are planning, if at all everything goes well after vaccination and all that. And if we are in a position to hold a conference, then definitely we will hold a conference. And that time also we will give 2 points. So the quota of 6 points will be finished by 31st March. This is a good news for all those who have renewed their membership. You must have seen on all TPA 4 groups, nearly 82 new members have joined in 2021, that is till today. And this is a very good number in spite of COVID. Had there not been a COVID, you know, on 2nd of April, Dhule Pathologists Association, they have taken the challenge to hold a regional conference, and everything was done practically. And at the end, the last week of March, lockdown was declared, so the regional conference could not take place. Otherwise, the whole preparation was there. Same was for Kolhapur people. They also were ready for a regional conference, and followed by immediately there was a Varsha conference as usual in the month of June. So this conference we would have definitely crossed 600 mark in no time. Because of COVID, things happened very slowly, and we had to sit silently at the outside. But still, 82 is a very great number for me, and very encouraging that people are willing to join and strengthen a pathologist association, which is a need of hour. There is no pathologist association of practicing pathologists for a state purpose. Association which deals with your academic activities, maybe CME, maybe conference, maybe seminar, maybe workshop, or association which fights for their rights, maybe in the High Court, maybe in the regional courts, or maybe in the Maharashtra Medical Council. It may be issue of capping of the prices, or it may be issue of signing pathologists. The Pathologist Association stood the test for all these years. Initially, we launched it as Thane Pathologists, and slowly we had turned for last 2 years to State Association. And today, only district which was not there, Sangli district, Dr. Raju had joined from Raju Gangwani has joined from Sangli, and all districts are representing in. We started with Thane, so naturally Thane, Palghar, and nearby Konkan, Navi Mumbai, and in due course of time, Mumbai. So that was a very strong hold of TPA. Things passed to Nashik. We had on 15 December last year, very big regional conference which was attended by more than 100 delegates. Nashik become fan of TPA. Now then Dhule, Nandurbar, and Jalgaon, all 4-5 districts of Khandesh, they are now a stronghold of TPA. And in last 2-3 conferences, we have seen practically from Nagpur to Solapur and from Kolhapur to Satara, people are coming. Maybe they are representing in small numbers, but definitely we are having inroads in all the districts as far as this CME text is today. The best specialty of our TPA CMEs and conferences, which is liked by all, is the subjects are not high flown. They are with need of our day-to-day practices and concerned with practicing pathologists. which we can understand and which we can follow and which we can practice. So these subjects that is a very speciality of us. Of course, we do with recent advances, and for conferences, you must have seen that even very big shots of national level, they have participated in our conferences. So these are a few words from my side, and nothing more to add. I think this is the right time. Number has also increased. Oh, I see something 185 plus 15, that is 200. So I request Dr. Supriya Chinsolkar to take over from me and to introduce the first speaker. Thank you.
Thank you, Desai sir. Good evening, everybody. And we are beginning with our first ever virtual pathology conference today. And it gives me immense pleasure to introduce this first speaker, Manish Dattatreya Karekar, who is a certified pathologist. Is my voice audible? Hello, is my voice audible?
I request the panelists to do not use multiple devices as it will create echo.
So it gives me immense pleasure to introduce Manish Karekar. He's a certified pathologist practicing as a laboratory physician from the past 13 years. He's an alumni and postgraduate in pathology from the TN Medical College, Nair Hospital, Bombay. He's technical assessor for NABL as well as ISO 15189. He's a certified Six Sigma black belt from the Indian Statistical Institute. A black belt in our midst. Wow. He's also currently in the Chief of Laboratory Services at Regional Referral Lab of Metropolis, Pune. And he heads the laboratory operations for the rest of Maharashtra. His key role areas are improving the quality in total testing process, which is short formed as TTP, and maintaining the operational expenditure. His areas of interest are continuous improvement in the TTP, in autoimmune testing, and in coagulation testing. It gives me great pleasure to introduce before you Manish Karekar, who's been along with me in my journey as a pathologist and a Thaneite and a school friend and also a Nairite. Welcome, Manish Karekar.
Good evening and thank you, TPA Desai, Supriya ma'am. You were also my lecturer in Rajiv Gandhi. So, it was a privilege and honor being introduced by Dr. Supriya. So, I'll be talking on interferences in immunoassay testing. So, I've named it as a Russian roulette. So, as you know, Russian roulette is a game in which there is a revolver with a cylinder. A cylinder usually has 6 empty spaces for bullets. One bullet is cylinder is moved, it goes back into the gun, and then it's a game. You have to just keep on alternating, and somebody dies. This usually used to happen. I was just searching what image I could put for Russian roulette, and then finally it dawned upon me this popular image, which I think everybody must be aware about. Gabbar Singh, kitne aadmi the? So this is one of the iconic images for Russian roulette. Here actually it is also a question in MBA where they ask you what is the probability of the first one getting killed, the second one getting killed, and third one getting killed. So how do you relate a Russian roulette to immunoassay? One thing is immunoassays, when and what will hit you, you will not be able to predict. So there might be a query after 1 month, there might be a query after 2 months. If you're lucky enough, you'll get a query in 3 days that we have tested your result somewhere else and it is discrepant. So is it discrepant due to lab? Is your lab correct? Is the other lab correct? Are both the labs correct? Are both the labs wrong? So this is absolutely detrimental to know the interferences in immunoassay. Also, we as pathologists do immunoassays. Some of us outsource it, but once we outsource it, the patient usually comes to us only for interpretation, not to the outsourced lab. So it is very essential for us as practicing pathologists to know about immunoassay interferences. The overview would be immunoassay basics. The basic revision always helps. Interference basics. What are the nature of interferences? What are types of interferences? So these are the different types of interferences: cross reactivity, hook effect, antibodies causing interferences, endogenous components in serum, as we know popularly, hemolysis, icterus, lipemia, protein levels, enzyme levels, pre-analytical interference, which is in which is in our control and it is not in our control. So
Dr. Manish?
Yes, sir.
Please 1 minute for. I wish you 1 minute break, please.
Yeah.
Yeah. Unmute yourself. Okay. Am I audible to all? There is a common question from all, and most of the people, they have not done their renaming. So we have instructed that in participants list, your name and your MMC number should be reflected. Most of you have not given your MMC number. What you require to do is pick your name. Excuse me, Mr. Aditya.
Yes, sir.
Can you answer this question? How they can rename the participant list?
So yes, so there is a general question in the Q&A that how to upload your photo and everything. So just to note that you do not have to upload any photo or anything. You just have to rename yourself and put your MMC number after your name. That should be enough for the MMC to credit the points. So I request again everyone.
How to
in
add,
the
that is the
attendees
question.
List. Yes, sir. I request everyone in the attendees list to tap on their name and rename yourself and put the MMC number after your name.
After tapping your name, there will be some dots where you can click the option of rename, and once that is done, you give the name of what is enrolled in MMC. Of course, you must have marriage afterwards, but what is the MMC name that you have to enroll, and then your MMC number. You please do the exercise and then we'll continue. We'll give 2-3 minutes. Have you all understood the
I think most of the people have understood. They are renaming themselves.
Okay.
Let's wait for some time, and
let's wait.
I think we should continue with the session. They will do the renaming in the background.
So carry on.
So shall I restart or shall I continue from where I was?
Yeah.
Sir, you should continue, I think.
So the overview of the presentation would be immunoassay basics, interference basics, cross reactivity and hook effects, antibodies which cause interference, endogenous components in serum like hemolysis, icterus and lipemia, also protein levels, paraproteinemia, pre-analytical interference, as in case of sample collection and sample processing, which can and cannot be in our control. Interference resolution. Interference is there, so how do you take care of it? Effect of analyte heterogeneity, that is, one platform gives one result, the other platform gives other results. Most of us as a practicing pathologist who do not do these tests, we are not aware about the variations. So I will just tell you how you can get these variations or where you can get this data from. Now, what are the requirements of immunoassay? First is we'll require an analyte in question, what analyte you want to measure. Second, there would be an antibody to the analyte to be measured, which will capture the analyte. Third would be a labeled second antibody to the analyte. This complex then gives a color or a fluorescence or a turbidity, and then there is a signal detection system which will give us a reading. Now, what is the strength of an immunoassay? Affinity. Everybody knows this. We have learned it through our undergraduate days. Antibody affinity is the strength of the reaction between a single antigenic determinant and a single combining site on the antibody. It is the sum of the attractive and repulsive forces operating between the antigenic determinant and the combining site of the antibody. This is a small illustration for the same. Now, what are immunotechniques or immunoassays? Now, if the analyte in question needs to be determined, antigen antibody reactions and the test are in vogue since past more than 60-70 years. So, primary techniques and secondary techniques. The primary techniques utilize the physical changes occurring during antigen antibody interaction for estimation. The secondary techniques utilize the labels or markers to estimate antigen and antibodies. They were developed specifically to increase the analytical sensitivity of assays. My seniors like Dr. Desai sir, Kulkarni sir, who have practiced 15-20 years more than me, they know that previously when radioimmunoassay was there, the TSH linearity was hardly 1 to 10 or 1 to 20. And there were gamma counters used to measure the T3, T4, TSH. However, now the sensitivity at the upper level is almost 100 and at the lower level is almost 0.01. So this is because of the newer techniques which have come and evolved. Coming to primary immunotechniques, it is the precipitin reactions. This is the interaction between an antibody and a soluble antigen in aqueous solution. It forms a lattice that eventually develops a visible precipitation. Now, agglutination, we all are doing that day in and day out. The interaction between antibody and particulate antigen, it results in visible clumping called agglutination. These antibodies produce such reactions called agglutinins. The precipitin reaction examples are immunofixation, immunoelectrophoresis, commonly seen in your multiple myeloma or your plasma cell dyscrasias, and these can be interpreted through the naked eye. Western blot test commonly done for HIV, it is slowly becoming obsolete now because of the viral loads and PCRs. Agglutination reaction, classically we know the Coombs test and blood group. Coming to secondary immunotechniques, two words which I'll be repeatedly using, and I have done that intentionally, is competitive and non-competitive. Non-competitive is also called as sandwich. Competitive is a limited reagent immunoassay. In the competitive assay, the higher the concentration of antigen in the sample, the lower is the absorbance. I mentioned absorbance, but this could be fluorescence, this could be luminescence. It depends upon what is the measuring principle of the assay. In non-competitive, also called as excess reagent assay, also called as sandwich assay, the higher the concentration of antigen in the sample, the higher is the absorbance. They are directly proportional to each other. This is a small cartoon which I've drawn. Competitive assays and sandwich assays. You can also observe that both are intentionally not made straight because both are non-linear reactions as compared to your routine biochemistry, like your glucose, your creatinine, as compared to that immunoassays usually are non-linear. So if you see the first cartoon of competitive assays, the lower the analyte, the higher is the signal. The higher the analyte concentration, which is the analyte concentration is on the x-axis. Higher the analyte concentration, lower is the signal. If you see on the sandwich assays, it is exactly the opposite. Sandwich assays are more simpler. It is directly proportional. This is a mixture of the two. So here I have taken two assays together, that is a competitive and sandwich. Let's talk about the low values. So if the analyte concentration is low, in competitive assays, the signal will be on higher side. In sandwich assays, the signal will be on the lower side. Now we go to the other end of the spectrum. When the analyte concentration is high, in competitive assays, the signals will be low. In sandwich assays, the signals will be high. This is extremely important. Even if you keep this as a take home, only one, I think my task is achieved. Let's go to next. Secondary immunotechniques. Now this depends upon the type of labeled immunoassay and what is the endpoint or measuring principle or the endpoint signal, how it is captured. So particle immunoassay we know is chemiluminescent microparticle immunoassay, but here it is a relative light units. So it is an absorbance. Fluorescent immunoassay, everybody is aware about mini-Vidas analyzer from or Vidas analyzer from bioMérieux. There is a fluorescence, which is the fluorescence is captured. Chemiluminescent immunoassay, Siemens, Roche, Beckman-Coulter, that is the access to analyzer. They all have chemiluminescent immunoassay. And enzyme-linked immunoassays are the ones like your traditional ELISAs which we do for dengue. So these are again photometric. Let's progress further to interferences in immunoassay. Now, what is an interference? It is the presence of an extraneous substance or external substance. I have not changed the language. These are standard languages from standard journals. So I've used these words. These are interference is the presence of extraneous substance in samples. It may cause change in measured analyte and it gives an erroneous result. Now, what can the interference do? It can cause a false increase or a false decrease in the analyte value. Now, what are the interferences in immunoassay? It's a single interference and a matrix interference. What do you mean by single interference? As I told you, it could be fluorescence capture, it could be absorbance capture, it could be luminescence capture. So if there's a problem in the capture, it is called a single interference. Now, why and how it will occur? It occurs when compounds which are capable of interacting with the signal detection mechanisms which are present in the sample. We commonly hear this word matrix interference. So what is matrix? Matrix is nothing but the common sample for us is usually a serum sample. The serum is a mixture of proteins, lipids, minerals, salt and water. All these components have low affinity for the binding antibodies and they may cause interference in immunoassay if the equilibrium of serum alters. Equilibrium, it means it could be a different organic condition, different disease states, nutritional supplements, medicines, drugs. So that alters the equilibrium. Now, the interference. So how do you classify these interference? Endogenous substances, exogenous substances. Endogenous substances. Now, previously when I was in 97, 98, when I was doing my graduation, Kawasaki's disease, Kikuchi's disease, Wegener's granulomatosis, I thought that these diseases don't happen in our country. ये इंडिया में थोड़ी होता है, ये रॉबिन्स में लिखा है. But it does happen and now everybody knows for a fact. So endogenous substances, these antibodies which I'm saying are very much there. There are labs who are testing for these antibodies. I will quote a fantastic paper from an Indian from an hospital in South who has done a fantastic study on this. So endogenous substances are autoanalyte antibodies. The common example is antidote for digoxin, which is digibane, heterophil antibodies, human anti-animal antibodies, and cross-reacting substances. Exogenous substances, we are aware of most of them. Hemolysis, blood collection tube additives. Most of us get samples from people who are not that much trained. So a lot of funny things happen in the blood collection tube. Drugs cause interference. Supplements, nutritional supplements, God knows what are there. Even if you do LCMS, half of the things are not known what goes inside these nutritional supplements. Exogenous substances, again, antibodies for treatment which are used, like for dog bite, antivenom, herbal medicines, icterus and lipemia. Now, types of interferences. This is how the now the presentation will proceed. So, types of interference, one is a hook effect, antibody, cross-reactivity, endogenous components and pre-analytic factors. And later I'll come to something called as analyte heterogeneity. So when to suspect? Now everybody must have heard the Feluda, which is the CRISPR. Now Feluda was a fictional character created by Satyajit Ray. So that's the drawing actually drawn by Satyajit Ray of Feluda, the taller person. He was a detective. So when to suspect, that is the most important. Now immunoassay interference is usually a reactive phenomenon. That is, you cannot predict an immunoassay interference. So that is the biggest drawback. You will come to know after it has occurred. But still, before releasing the reports, you can always be sure while releasing the report, also while handing the report to the patient. So when to suspect is lack of agreement between individual results obtained as a profile. So T3, T4, TSH all are low, T3, T4, TSH all are high. In an 8-year-old girl with precocious puberty, the hormonal levels are low. So these are few of the examples. Results are unusual or least expected. Worst is when clinician and patient tells you that there are issues in reports. How do you go about it? Again, this character would be quite known to us, Byomkesh Bakshi. Now, how to detect? Repeat the test if you have the sample. Ask for a fresh sample. The most important thing, read the pack insert. Sandwich assay, you need to repeat in dilution. I'll elaborate that. Competitive assay, rule out cross reactivity. Look at any alarms, flags which might be missed while releasing the reports. Further check for clinical details. As I told you, an 8-year-old girl with a precocious puberty, the doctor calls back saying he was expecting high hormonal level because the girl has got puberty. So check for clinical details. Repeat assay by other measuring principle. I have one analyzer. Your peer has a different analyzer. You can speak to them, send a sample, get it cross-checked. Treatment by PEG and blocking agents. PEG is polyethylene glycol. Speak to peers operating on similar analyzer systems, as I just told you. Refer sample to higher centers. There are a lot of higher centers doing this. Now coming to cross-reactivity, which is one of the important interferences. The cross-reactivity occurs when substances structurally similar to the analyte or those that possess similar epitopes. Epitopes are nothing but a part of an antigen. Similar epitopes to the analyte are present in serum and they form complexes that produce measurable signals. It commonly affects the competitive immunoassay. Liver disease and kidney disease. Now what happens is in chronic liver disease and chronic kidney disease, it results in formation and accumulation of metabolites, and these metabolites are usually cross-reacting products. This is from the pack insert for estradiol. This is taken from the analyzer called Abbott Architect, which is a CMI method. Estradiol is a competitive immunoassay. Now, if you see here, there's a long list of hormones which are there, which interfere with estradiol. Why I've taken estradiol is estradiol in breast cancer, usually tamoxifen or formoterol is a drug which is given, which is an anti-estrogenic drug. Now I will come to the further elaboration of this. Is for an anti-estrogenic drug is given if the patient is ERPR positive for CA breast, and it is monitored by the estradiol levels. So Architect method interferes with estradiol measurement if the patient is on this drug, which is clearly mentioned in the pack insert. So if you miss this, you will be end up giving a wrong report. So here reading a pack insert is of absolute detrimental importance. So now if you see here, they are close to 50-60 analytes which are mentioned. These cause cross reactivity. Coming to one of the most important thing, everybody knows this. It is popularly called as hook effect or also prozone effect in immunoassay. It is seen with Vidal test. It is seen with your pregnancy test. Usually, the commonest example is in a case of choriocarcinoma. It is very frequent to have this hook effect for HCG estimation. Now, what is this also called as? It is called as a prozone effect. It is seen in sandwich assays where the excess analyte concentration interferes with the sandwich complex formation, giving rise to falsely low results. The bottom side, why it is called hook? Because it resembles a fish hook. If you invert this hook, it will exactly how a graph will look, which I've explained in the next page. Now, this is the graph. If you see here, the x-axis represents the analyte concentration, the y-axis represents the signals. The LOQ is nothing but limit of quantification. So LL is called as lower limit of quantification, is the vertical dotted line. The horizontal line is the limit. The sort of linear graph between the upper limit of quantification and lower limit of quantification is actually called as a linearity of the analyte by the analyzer. If you further trace this, you reach a nadir or an apex, which is called as the anchor point. Once the concentration crosses this anchor point, if you see, the signal levels drop down drastically, but the values are extremely high. So this is called as a hook effect. So they are falsely low signals. This results in an erroneous results if you don't correlate with the clinical conditions. So again, just to elaborate further, if you see the cartoon here, the red is the analyte. if you see there are a lot of analyte positions which are free. So analyte is binding to both capture as well as detection antibody, leading to reduction in the formation of antibody antigen complexes, and thus it decreases in signal at a higher concentration of analyte. Now, what we do if it is a hook effect? We dilute it. We should remember one of the most important steps in immunoassay is you cannot dilute till you want. There are specific levels which are mentioned in the pack insert to which you can dilute. I've just taken an example of estradiol here. Now my machine has a linearity of 1000. So if it is above 1000, I dilute the sample. Now with what I dilute, there is a universal diluent which is given. The way we work for biochemistry, a normal saline chal jata hai, it doesn't work that way in immunoassay. You have to have because being a closed channel system, most of the times you have to have a specific immunoassay diluents. If you see here the yellow arrow, it clearly mentions the concentration of diluted sample should be greater than 100 picograms per ml. For example, if I dilute it 1:10 and I get a value of 72, I cannot release a value of 7200. Or if I dilute to 1:100 and if or 1:20, whatever dilution I do, if the value is less than 100, I cannot report that value. So you have to read the pack inserts because every analyte has different dilution level. For prolactin it is 25. For estradiol it is 100. So you should always remember there is only a limit to which you can release a value in immunoassay. Beyond that, you have to release a value of more than 10,000 or more than 20,000 depending upon your pack insert. Now, antibodies interfering in immunoassays. These are heterophile antibodies or human antibodies in a specimen that interact with the assay antibodies. They are raised, the assay antibodies are the ones which are raised in different animals, like it could be murine, it could be rabbit, it could be sheep. Now, in this case, it provides falsely increased or decreased results. This interference by antibodies is observed in all assays, be it competitive or non-competitive. Now I'm just explaining this. The cartoon A shows how ideally the reaction should happen. So this is a typical immunoassay in which the analyte in green. This is an old picture, but it looks like a coronavirus. But that's the analyte in green. To the left is a capture antibody, and then there's a labeled antibody. This is the complex which gives rise to the signal. Now you go to B. Here, what happens is you get a falsely high value. The analyte is not there only. The heterophilic antibody captures the labeled antibody and the capture antibody. Here you will get falsely high values. But if you go to picture C, you will get a falsely low values in the presence of heterophile antibodies. This is a fantastic article which has been published by Dr. Jayesh Vardhe from Meenakshi Mission Hospital, Madurai, Tamil Nadu. They have done a study which ran over 6 months, out of which 87,780 tests were done. They got 42 discrepant immunoassay results. Now if you just quantify, I was just calculating, it comes to one interference every 5 days, which cannot be explained. They are doing 500 tests a day. So if you are doing 1,000 or 2,000 tests a day, actually you are releasing one interferent report every day, which you are not aware about. Heterophile antibodies contributed to 15% of these 42 cases, which were around 9. The prevalence of heterophile antibodies is known to be as high as 40%, and interferences in immunoassays 2%. This sounds pretty Greek, but knowing that most of the population is in the rural areas where animals are a source of living, obviously a lot of animal handlers in the rural areas have these antibodies, and in the urban areas, obviously pets can give rise to these antibodies. Blocking antibodies are available commercially in market. They're extremely expensive, but they are available. Coming to the other part, other than heterophile antibodies, these are autoantibodies. Now they can affect both sandwich and competitive assays. The sandwich assays, it can cause falsely low results. Competitive assays, it can cause falsely high results. Please remember, competitive assay is inversely proportional. Lower the concentration, higher is the signal. So, and in sandwich, it is directly proportional. Examples, the antidote for digoxin, digibin, it commonly interferes. Antibodies to troponin, it causes a falsely low result, which could be a fatal. You would be giving a false negative result if the antibodies already, autoantibodies already existing to troponin. Blocking reagents eliminate the effects of interfering antibodies. However, you have to investigate the case further and give it. So obviously, after testing it for blocking reagents, only you will come to know whether it is there or not. So you have to always keep in mind, it is very important to find a solution, because you will lose the patient and the doctor, and obviously it will affect your inflow of patients. Endogenous components in serum, the three villains which are always there: hemolysis, icterus, lipemia. Elevated concentration of serum components such as bilirubin, hemoglobin, lipids, and proteins may interfere in assay depending on the signal detection mechanisms of the immunoassay or labels used. Labels is again the fluorescent label, luminescent label. Most of the autoanalyzers can detect all the three interferences and they can flag the results. Now, endogenous components in serum, greenish color, icteric. So bilirubin causes interference due to its fluorometric and photometric properties. Red due to hemolysis. Hemoglobin, hemoglobin has photometric, fluorometric, and luminescent properties. Turbidity due to lipid, that is the chylomicrons or VLDL. In photometric assay, they interfere usually due to scattering of light. Viscosity, protein. So hyperproteinemia, if you read the pack inserts, whoever does immunoassays, who don't do immunoassays, speak to the lab who sends it. They can send you one pack insert of an immunoassay. Just read it, what are the interferences. So it always says that protein level less than 3 and more than 12, there is an interference which is noted in immunoassay. We tend to overlook the part of proteins. It causes increase in viscosity. Increase in viscosity will differ the kinetics. Parag Gaurav sir, a fantastic speaker. I think he's going to speak on Sunday on biochemistry. Endogenous components in serum. This is again the pack insert. I'm just reading it out. Potential interference in the architect estradiol assay from hemoglobin, bilirubin, Tg, protein, and cholesterol at the levels indicated below is less than 10%. Interference was evaluated in the study based on guidance. So every particular analyte will have a different interference level. So hemoglobin will be 500 in one component, it could be 250 in other component. So these are the common. Just look at protein. So at 4 and 12, so in multiple myeloma patients or Waldenstrom's macroglobulinemia cases, a protein more than 12, you will have to be very careful in releasing the results. This will only happen if you take a history. Endogenous components in serum, now just clarifying those, I'm just talking about proteins. So hydrophobic analytes like steroid hormones, thyroid hormones, drugs, they're affected by protein levels. Few assays are developed to test the free component of these analytes. Few assays have developed releasing agents that free the analyte from the proteins. So you get a proper analyte concentration. Obviously, the manufacturing companies are doing this for so many years. So we frequently know that there are different generation of analytes which are released. Those who do immunoassay, we know that a new generation comes. The software engineer, the application engineer comes, he changes the program. Now this new generation, what it comes is, these developments are done by these immunoassay reagent companies from time to time. And this is essentially to take care of the interferences and also to improve the sensitivity. Paraproteins, multiple myeloma patients and Waldenstrom's macroglobulinemia cases, they have high IgG levels. This causes precipitation during assay reaction. Now, usually when an immunoassay happens, it could be an alkaline medium, it could be an acidic medium. This causes precipitation of these paraproteins. Now, what precipitation does is it causes turbidity in the analyzers. Now it causes turbidity in analyzers which use sample blanking. Now we know what a sample blanking is. It is usually done to eliminate the interference of the sample. It is done in hemolysis, it is done in icterus, it is done also in turbidity. So there are few analyzers who do sample blanking, And this turbidity, what it does is it contributes to increase in the background blanking. This results in a falsely low result. The interference is noted in the thyrotropin assay in CMI due to high immunoglobulin GK. How do you resolve the interference? The sample should be serially diluted by appropriate diluent as per the pack insert. The result of the most diluted sample within the linear range of assay. As I told you in estradiol, you have to see what would be the minimum range that you can report on. So the result of the most diluted sample within the linear range of assay should be multiplied with its relevant dilution factor to obtain the correct analyte level. Just for the uninitiated, what is a sample blank? Now the spectral interferences, that is the photometric interferences, can be minimized by measuring the absorbance of the assay against the sample blank. The simplest sample blank is obtained by mixture of a sample and a diluent. Correction for the interferences is made by subtracting the absorbance value of the blank from the absorbance of the complete reaction mixture. In case of fluorescence, sample blank allows for the correction of non-specific fluorescence as well. Proceeding to pre-analytical interferences, here it's age, time of collection, posture, pregnancy, medications, underlying diseases, if any, as I mentioned, kidney disease, liver disease, anticoagulant used. There are a lot of, as I said, there are a lot of funny people doing funny things, and there are a lot of intellectual people, in order to improve the turnaround time, are doing verification, doing further studies. So that has come to know how a plasma can also be used for immunoassay, but you have to be very vigilant and you have to have stringent verification protocols. Stress is very important. Coming to pre-analytical interferences, age, it is related reference ranges, particularly for neonates and infants. Time bound, we know cortisol 8 a.m., 8 p.m., ACTH, testosterone, prolactin. One thing about prolactin, you should be very careful, is it is an acute phase reactant. So be very careful while reporting a very high level of prolactin. So if you get a repeat high level of prolactin, there's something called as pooled prolactin, there's something called as macroprolactin. So isolated high values of prolactin without any history, please look at it as an acute phase reactant. Drugs, exogenous uses of corticosteroids cause direct positive interference in steroid immunoassay. Fulvestrant, we have learned the hard way, it is an anti-estrogenic compound which is given to CA breast patients who are ER/PR positives. It directly interferes with estradiol estimation by CMI. It is clearly mentioned in the pack insert that do not process sample for patients who are on fulvestrant for estradiol monitoring on Architect. This is a fantastic article again by GCP Lippi. It tells about postural change during venous blood collection. It is a major source of bias in clinical chemistry testing. What they did is a set of 50 people, they tested in supine position. After 45 minutes, they tested in sitting position. After 45 minutes, they tested in standing position. So what happens essentially is in change in posture from supine to sitting is the intravascular fluid migrates to extravascular spaces. So the larger proteins remain in the circulation. So this causes the commonest example, the hematocrit increase, and it is statistically significant. So there's an increase in concentration of larger molecules. So the recommended position is sitting position, which is preferable. And this is what we commonly do in our blood collection of phlebotomy rooms. Moving on, pregnancy, increase in the protein binding of hormones cause positive interference. So free component assessment is recommended. Everybody does FT4 now in pregnancy. Stress, it causes increase in growth hormone, cortisol, catecholamine, and prolactins. Sample collection, serum is the sample of choice. Fluoride is an enzyme poison. That's the reason fluoride is not preferred. EDTA and citrate causes positive interference in competitive assay and negative interference in sandwich assays. There are few hospitals who have done a verification study on lithium heparin, using lithium heparin plasma for immunoassay as well as clinical chemistry. However, a stringent verification needs to be done because lithium heparin plasma also interferes with few immunoassays. So, because it's an emergency in hospital setup, it is a part of triage. They have to release reports urgently. A set number of immunoassay parameters, if they are satisfactory in verification, you have a good verification, strict and sturdy verification protocol. Now, lithium heparin plasma is used for clinical chemistry and immunoassay in some of the hospitals. I'm again coming to this, Vyomkesh Bakshi, interference resolution. Repeat the test if you have the sample. You can keep the sample depending upon the rarity of the analyte. So right from 3 days to 7 days, you can store the sample. Ask for fresh sample if you don't have it. Read the pack insert. There is no substitute for reading the pack insert. Sandwich assay, you'll have to repeat in dilution again after reading the pack insert. Competitive assay, please rule out the cross reactivity. Look at any alarms, flags which might be missed while releasing the reports. This is last few slides, but I think these are few interesting slides I wanted to make a part of. It would not take much time, 5 to 10 minutes more. Effect of analyte heterogeneity. Many analytes exist in many isoforms. The commercial immunoassays use different antibodies to the analyte isoforms. We have faced this day in and day out. TSH value from one lab, TSH value from other lab. Now this is the reason. This is depending on the concentration of various isoforms. What I've done here is, this is a Biorad ECAS results of, I've just taken 4 immunoassays just to explain to you what is the difference of the same sample if it is tested on different platforms. Now here I'm not going to name the platforms. This usually means that both the analyzer results are correct. Now how and who is going to interpret is a big question mark, and we have to face the music as a laboratory physicians when patient comes to us. So if you see here, one analyzer has given a value of 73 of PTH, the other analyzer has given a value of 128, and the values vary from 73 to 128 on 8 different platforms. All are absolutely reputed platforms. This is about PTH. Coming to next parameter, ferritin. So ferritin, I think I'm not able to see the minividas result, but the minividas results was in mid hundreds. So an Abbott result of 217 against a minividas result of 114, and all results varying from 114 to 217. Now this happens because of platform. And microparticle immunoassay against a fluoroimmunoassay. So if you get different conflicting results from 2 labs, call the lab, ask them, ask for a pack insert, and we can explain the patient and the clinician, because we as a referring lab are in a soup to face the patient with such conflicting results, and both the results are essentially correct. Coming to HCG, again, if you see here a value of 1000, here the funny part is, I'm not going to name, but both are the same company with different platforms. So one value is 1032, the other value right at the bottom is 1886. Now if I give these kind of values to a IVF person, I think I will have to hear a lot of cuss words. But this is a fact, and this is immunoassay testing. You should know what we are giving as values, and we'll have to speak to the doctor accordingly. So what is recommended in immunoassays is in tumor markers, in hormones like E2, HCG, where serial estimations, please stick to one platform. Don't keep on changing platforms, because with the same company, you will have results varying from 1032 to 1886. This is HCG I'm talking about. Coming to progesterone, again, I think I'm not able to see the bottom values, but the bottom value, as I remember, was 9. So results are varying of the same sample from 9 to 16. Just to give you a feel of things, both the values are absolutely correct. One more important aspect is the analyzers. Which analyzer, what analyzer, we don't do the test. The pathologist, one who has released the report, says I am correct, I'm just giving you an example of 4 analyzers. Roche is an immunoassay. There, each sample is picked up by separate tip. So a carryover cannot occur. That's what they say, because there's a tip is different. If you go to a minividas, again, a minividas will have, it's a semi-automatic, it's a fantastic analyzer, but however, it involves a semi-automatic step, that is a manual pipetting is involved. Let's come to the other analyzer called, other 2 analyzer, one is CMI, one is CLI. Both have a probe. So in these 2 analyzers, a carryover can occur. So a carryover study is extremely important. So if a hypothyroid patient with a TSH of more than 100 and a second sample is of a hyperthyroid person with a TSH of 0.01, and if there's a 5% carryover, so just imagine a 100 TSH value with a carryover to 0.01, the report might go as normal. So these are small things which are there in immunoassay. So you have to be extremely vigilant while interpretation, releasing the reports, handing over the reports. I think I'm not boring you guys further. I love this topic. I can talk forever, but I have to end because it's a very interesting topic on histopath taken by Dr. Vinita. The take-home message is competitive assays. The analyte concentration is inversely proportional to the signal. Sandwich assays, analyte concentration is directly proportional to the signal. Hook effect is seen only in sandwich assays. Common in urine pregnancy test, VDRI test, VIDA is a waste basket test, but still. A hook effect is seen only in sandwich assays. Immunoassays become non-linear, so do not interpret without reading the pack inserts. Different platforms from same analyte different values, and both the values are correct. So you are in fix while interpreting, but that is the whole game is all about. So I'm done from my end. This is my phone number. I'm there in most of the groups. Feel free to ask or ping me. That's my email ID. One of my favorite flowers. Thank you very much. I'm not able to hear anything.
Sorry. Now am I audible?
Yes, sir. I'll stop.
Yeah. Thank you very much, Dr. Manish. It was a fantastic lecture. These lectures photographs are shot and are displayed at all the TPA4 groups by many people. So those who have displayed the photographs, they are definitely awake and they have participated. That is the proof for MMC. And you must have seen the change. We have asked the organizers to add. Let me, at this point of time, thank DigiShield, and the CEO of its DigiShield is Mr. Mehta, and who has done this very difficult management with a very short notice. There are definitely hiccups and some deficiencies, but we'll have to adjust with this because we too are also new to technology, this kind of technology, and we are not software specialists. It is very difficult. So simply just I can send a message. Just don't bother if you are not in a position right now, add profile photo. But afterwards, after this CME is over, in your mobile application or whatever it is, you can add photograph taking help of persons who are techno-savvy. Now most of the names I am seeing, they are showing the names with their MFC numbers. I find Dr. Ravindra Shindre is not showing the MFC number. What you can simply do is, Now you are in a position to see the participants list, participants at the bottom. You are able to see participants. You click the participants, then you will find your name. Or alternatively, if you are in a position to click the name on the screen itself, click the name, you will find that there are 3 buttons coming at the right top of your photograph. Only whatever the area is allotted to you, at the top right corner, you are finding 3 dots. Click them, you will find rename option. Here you rename. If you have given the life care diagnostics, you change it. You make it Dr. Jinkar Desai and whatever the MMC number is. So now you can make, and Dr. Swarup, you please take the photograph of all the different things once everything is said. The seminar, the webinar is also important. The contents are also important. But the most panic situation for my friends is about the MMC point. As far as I am there, simply just don't bother of MMC point and be relaxed and be cool. Don't post any message henceforth on WhatsApp group. It will create a very bad message those who have not attended. Please, request. Don't post any message. If you want to post any message, you post to me directly. Discrepancies are always there because this is our first endeavor. We are not doing it for years together. Even we know when we conducted a live CME in Kaushalya, there were hardly 10 people and there were 5 people to give lecture. It included Parag Dharap and Charu. They were celebrity. But because of our friendship, they came and they found that there are just only 10 people in the audience. These things happen. We have come across. So you got all. If anybody is not able to get, I will again repeat, because this is the most important part. And once you go out, don't try to come inside. You can listen to the webinar outside, because another capacity of this video is of 100. And for audio, it is 200, 230. So those who are not having numbers, we have taken them for video purpose so that they can change their name. So go to the participant, click there to find participant list, or alternatively you find your name and click the name. After clicking the name, rename option will open. Click on the rename and change your name. अरे बाबा, या सगळ्या स्क्रीनच्या बॉटमला एक पार्टिसिपंट म्हणून लिस्ट आहे. ते क्लिक करून तुम्ही तुमच्या पार्टिसिपंटच्या लिस्टमध्ये जाऊन तुमच्या नावावर क्लिक करू शकता. अथवा तुमच्या नावावरती इथे बघा, हे नाव असेल ना, हे फोटोग्राफ, तर खाली खाली तुमचं नाव आहे, त्या नावावरच क्लिक करा जिथे येते तिथे आणि ते चेंज करा. समजा झिनतमन आला असेल तर चेंज करा आणि अनुपमा वर्मा करा. अनुपमा, सॉरी, Anupama Verma is better than Jinadaman. Am I right? I agree. So Vinita is smiling because she's the next in the run. And I hope you have all done. And as regards certificates, simply don't worry. There is no high. कुठे पळून जात नाहीये. पण तुम्हाला डिजिटल सर्टिफिकेट करून तुमच्याकडे ईमेल वरती ते येऊन जाणार. You will all get digital certificate on email. Certificate pattern is, everything is ready, and Mr. Mehta of DigiShield is very cooperative. He has made elaborate arrangement for all this, and he has done it with lot of patience on behalf of Pathologists Association. Mr. Mehta, sir.
Yes, sir.
And Mr. Aditya and whole of their team. We are all thank you from bottoms of our heart. And
welcome, sir. No issue. We are there for doctors.
We wish still a better kind of service because they are elaborate service. After registration, they have sent you mail, they have sent you link. And what is the point of opening the link at 2 o'clock? I don't understand. And the seminar is to start at 4 o'clock. People are opening the link at 2 o'clock and this is not opening, that is not opening. What is this? I don't understand. No, you be conversant with this new technology, because we'll have to take help of this. Now we are stuck up that there is a number challenge, because in due course of time, Mehta sir, we will have 500 people attending the webinar. 500 people will be attending the webinar. Are you geared up for the 10th January webinar? That we will be able to all see all the people, and we have something like 500 capacity.
Yes, we have done that. For 10th,
Yeah.
there will be capacity
For
for
10th, I want to see all the glamorous faces of my Pathologists Association. Thank you very much, and I invite Dr. Janvi Ahuzao to introduce Dr. Vinita Pandey. Thank you.
Very good evening, everyone. It is my pleasure to introduce the next young and dynamic speaker, Dr. Vinita Pandey. She has done her MD in pathology from KEM and has a diplomate from Royal College of London, UK in histopathology. She is a director and consultant surgical pathologist at Acura Healthcare and Diagnostics, Mumbai. She has special interest in oncopathology, and her center caters to all and oncopathology services under one roof, including IHC and frozen section. Today she will guide us with a practical approach to skin adnexal tumors. Welcome, Dr. Vinita.
You're not audible.
Dr. Vinita, we can't hear you.
Aditya, she's not audible.
Can everyone hear me now?
Yes.
Yeah, I think I muted myself. Thank you, Dr. Janvi, for a very kind introduction. So today's topic that I chose was approach to diagnosis of skin adnexal tumors, which we often see very commonly. Now, the thing is that all the skin adnexal tumors kind of look very similar to each other, and we often get confused what to name them. Many people say that exact naming the tumor is not necessary till the point that you can classify them as benign and malignant. That is enough. But the thing is that many of the features of benign tumors, especially benign hair follicle tumors, overlap with your basal cell carcinoma, which is a very common malignant skin tumor. And that is where most confusion arises. So this is going to be a very practical approach to diagnosing and reporting our day-to-day skin slides. I'm not going to share much of theory, because for that you can, of course, consult your books and internet. So now a very practical classification to skin adnexal tumors would be in 3 steps. So first, as soon as you place the slide under the microscope, you need to decide whether the tumor you're looking at is benign or malignant. Once you've decided that, more than half of your job is done. Now, the second step, you move on if you can find out what is the lineage, whether it's hair follicle differentiation or whether it's eccrine or apocrine. And if you're done to that, even step 2, if you've finished, it's good enough and you can report it. And if you can do the step 3 and exactly name the tumor, then that's good enough. Now, the problem is that the first step is the most difficult step, and that is benign versus malignant. So you have to have 2 questions thoroughly answered. First is whether it's benign or malignant, and second, that has it been completely excised or no, because that is what is the most important information for the surgeon. Beyond that, he's not interested whether you call it A or you call it B. Now, it is not at all as easy as it sounds. Benign versus malignant is the most difficult part here. And why, I'll tell you. Because malignancy is not, usually when somebody says malignancy, the first few words that come to our mind is atypia, pleomorphism, mitosis, and that is what most of our reports that we describe have these words as soon as we say malignant. But malignancy is not always equal to atypia, pleomorphism, or mitosis, especially in skin adnexal neoplasm. You can have a very, very naive, very benign looking neoplasm, and that can still be malignant. Okay, for example, I have now placed, there are 5 photographs of tumors which almost look similar. They all are basaloid and they all, there's not much atypia or not much mitosis. Now, which is BCC? Because all of the above or none of the above? Now, this question is very difficult because we all know that basal cell carcinoma itself has so many variants, and all of these photographs would probably fit into any one of those variants if you go on to read the books. So how to solve this diagnostic dilemma? So now, one of the most celebrated dermatopathologists, Dr. Bernard Ackerman, he gave out some criteria, and he said that silhouettes, which is the shape of the tumor, always outweighs cytology when you're looking at derm path, especially skin adnexal tumors and even for melanocytic tumors. So shape of the tumor is always the first thing. The architecture is the first thing. So there are these 8 points here: symmetry, circumscription, orientation, stromal clefting, and type of stromal clefting is also important, not just stromal clefting. Appearance of the stroma, shoulder of adnexal structure, single cell infiltration, and then in the end, we have necrosis, mitosis, atypia, ulceration, all of those things which we normally see first in other tumors. Those things always come in the end. Now, let's look at what do these things mean. What does symmetry, circumscription, and orientation mean? So these 3 things are what comprises your silhouettes or the shape of your tumor. So let's see. For example, your tumor, a benign tumor, a benign skin adnexal tumor on low power, as soon as you place the slide, should always be symmetrical. It should have a geometrical shape, and it should be well circumscribed, okay? And it should have a shoulder. Now let's see what all these things means. So by symmetry, if you draw an imaginary line in the middle of the tumor, you should be able to fold the 2 halves of the tumor equally. If you're not able to do that, your tumor is not symmetrical. Then it can have any shape. It can be circular, it can be oval, it can be inverted triangle. Even triangle is a symmetrical shape, so that is not infiltrative, and we'll see it in another later slide. And the third point is it should have a shoulder. Now, what exactly is the shoulder? Now, can we see here? Now, shoulder means that at the end of the tumor on both sides, you must have adnexal structure. If you see adnexal structure on both sides of the tumor, for example, here and here, just look at my pointer, that means that the tumor is well circumscribed. It is between 2 adnexal structure and it has a shoulder. So tumors which have a shoulder on both sides are usually benign tumors. That's a very important clue. Now, if you look at this tumor, most of the people might say that it is not symmetrical, but I would still say it is symmetrical because it is, okay, you can't draw a circle or an oval shape, but then it is definitely lobular. And if I have to draw a symmetrical structure, it would be an inverted triangle. So even this is a symmetrical tumor. So do not call it an unsymmetrical tumor. Even this is a symmetrical tumor and it is benign. Okay, so orientation of the tumor can be vertical and horizontal. So if it is vertically oriented, it would have an inverted triangular shape, and that would also be a symmetrical tumor. Now, the second point that you have to look on the low power is that always make sure that you are able to see the base of the tumor. A biopsy like this, which I have shown here, is a very dangerous biopsy to report on because you cannot see the end point of the tumor. So you do not know whether this is benign or malignant. Although the cells may look very naive, but it can very well be a microcystic adnexal carcinoma. Now, let's come to the next point, clefting and stroma. The moment the term basal cell carcinoma is uttered, the first thing that comes in the description to our minds is clefting of the stroma. Now, clefting can be two types, and clefting can also be seen in benign tumors. For example, I have shown two tumors here. This tumor is also showing clefting, and this is also showing clefting. Or here, the clefting is very, very pronounced, but one of them is benign and one of them is malignant. Now here, if you see on the right hand side, there is a predominant clefting between the stroma and the tumor directly. So there's a space between tumor cells and the stroma. So this is tumor and stroma clefting. Whereas if you see here on the left hand side, the clefting that you can see wisps of stroma surrounding the tumor cells, and then there is clefting. So here the clefting is between stroma and stroma. So do not get too carried away by clefting. Please go on HiPAR and see what the clefting is. A stroma clefting is seen in benign tumors. Unless you see a clefting between true tumor cells and a tumor stroma clefting, do not label it as BCC. BCC always shows tumor stroma clefting and not stroma and stroma clefting. So now, why is there why is the stroma myxoid in BCC, and why is there tumor stroma clefting in BCC? Now, basal cell carcinomas, they produce lot of mucinous polysaccharides, and during processing, most of these are lost. And these spaces that you see are actually artifactual spaces because of the loss of those mucinous polysaccharides. And these mucinous polysaccharides are the ones that give stromites the another very important clue that we can see in skin with basal cell carcinoma that most of us probably do not report or put down in our report, but it's a very important diagnostic clue that can give you idea that okay, this is a basal cell carcinoma, and it is present here, and it is not in the tumor, it is in the stroma besides the dermis beside the tumor, and this fluffy thing, that pink fluffy thing that you can see. Now it has a bluish tint. So this is nothing but actinic damage. And we all know that UV rays are responsible for the pathogenesis of basal cell carcinoma. So this is called mucinosis of collagen or actinic damage that you will always see in tissue surrounding the tumor islands. So always look for clues other than the tumor itself, which will support the diagnosis of your tumor. Now, the last point that we go on to is necrosis and malignancy. Now, we always equate, most of the times we equate necrosis with malignancy. Now, I have put in this case, it's a 38-year-old female with flesh-colored nodular mass, which was small, 2 by 2 centimeters on the face. The overlying skin was excoriated, and this was reported as sebaceous carcinoma actually, and this came for second opinion. Now, if we see there, this area probably shows the ulceration or the excoriation of the overlying skin. And then what was labeled in the report, somebody had called it necrosis in the tumor islands. Now, what was labeled as necrosis was actually this eosinophilic pink material in the tumor islands, between the tumor islands. And there was indeed a lot of mitosis in the basaloid part. Pink thing, if you see, this is just plain eosinophilic pink thing without any apoptotic debris. So I would not call it necrosis. And if you see, you can see ghost outlines. If you look at my pointer, you can see ghost outlines of epithelial cells. So these are nothing but secretions. Now, sebaceous glands are the ones that have holocrine secretion. That means that the entire cell dies to produce sebum. So if you see, these are nothing but sebocytes, and this is actually, the pink thing is actually sebum, and it is not necrosis. There is no apoptotic debris here. So this is nothing but sebum and holocrine secretions of the sebaceous glands. And yes, you see mitosis, but this mitosis was limited to the basaloid part of the tumor. And also that there were no atypical mitosis seen. Okay, so the diagnosis is definitely a sebaceous neoplasm. Now, benign or malignant? Yes, I feel it is benign because as we see, this appears quite lobulated. This has a shoulder, although there is excoriation, but this has a shoulder, appears very lobulated and circumscribed. And what was thought of as necrosis is not necrosis, but holocrine secretions. And the mitosis which was there, it was present only in the basaloid part of the tumor. So points in favor of benign I've already mentioned, and worrisome feature which was mitosis and necrosis was necrosis we've discussed, and mitosis was only in the basaloid portion, and there were no abdominal. So now if let's compare this eosinophilic secretions with actual necrosis in a sebaceous carcinoma. Now, if you see, this is actual necrosis, you can see nuclear dust and nuclear debris here. Whereas if you see the eosinophilic secretions, there is nothing. So don't get carried away. If you see something in the sebaceous islands, pink things with ghost outlines, it is not necrosis. Okay, so be aware of what looks like necrosis and mitosis in sebaceous neoplasm. And the basaloid portion of the sebaceous neoplasm can show brisk mitosis. So don't get overwhelmed by them unless it's showing atypical mitosis. It is benign. So don't get too anxious. Now, this is holocrine secretion, whereas this is actually necrosis. Okay, so the final diagnosis in that case was sebaceoma. Now, that the common pitfalls that you usually encounter in skin adnexal tumors is that number one thing to remember is that a superficial cutaneous ulceration or other excoriation, it does not always indicate malignancy in a skin adnexal neoplasm, because your large sphiroadenomas, perianal hydradenomas, proliferating tricholemmal tumors, they often ulcerate the epidermis and can show a lot of mitosis, atypia, and pleomorphism. Basaloid cells in sebaceoma can show brisk mitosis. Please don't get misled by that. And also be careful of what you're labeling as necrosis, especially in sebaceous neoplasm. Make sure that it is not the holocrine secretion. Now, we have passed the first step, which is deciding whether it's benign or malignant. Now, let's come to the second part, which is looking for the differentiation. Now, if you see, if we have to divide the entire set of skin adnexal tumors, the majority is your hair follicle tumors. And then your ecrine, apocrine tumors and sebaceous tumors form very, very small component. Now, hair follicle tumors are the most difficult to name actually, because all of them actually look alike. So let's, and it is very difficult if you go on to read the books and then try and remember the features or try and memorize and remember the features. It is very, very difficult. So let us approach in a very, very commonsensical way. So to start with, first, we should know a very basic concept on keratinization. Now, epidermal keratin is something which you see on your normal epidermis. It is lamellar. It is lamellar keratin. The granular layer is very prominent and it never calcifies. On the other hand, the pilar keratin, or the keratin that is present in your hair, that is amorphous, that it doesn't have this lamellation. The granular layer is not prominent, and this is the type of keratin that calcifies. Okay, so if you have a tumor with keratin and calcification, you can close your eyes and label it as hair follicle tumor. So now parts of the hair follicle, I know it is this slide only looks very scary to know that how to remember each and every part of the hair follicle with the histology, but it is important to know the histology of the basic hair follicle, because the tumors arising from the different parts, they recapitulate the exact histology of the normal follicle. So, and if we remember by that, it will be very, very easier to differentiate the tumors. So let's see how. Now, basics histology of the hair follicle. Now let's see here. So hair follicle, we can just divide it in the parts: infundibulum, the part which is in the epidermis, then the isthmus, that is the neck, then the stem. Now, isthmus and stem, they are in the dermis, and the bulb, which is deep down in the dermis and the subcutaneous tissue. Now, let's see what the infundibulum looks like. The infundibulum looks
The talk has got disconnected. Mr. Mehta.
Aditya.
Yes, sir.
We've lost the
I
display.
think doctor has lost her connection.
Acha, doctor has lost the connection.
Yes, yes.
Yeah.
I think somebody should call her up.
So, Sarup.
Sir, I'm calling. Sir, I'm calling.
Yeah. Let's see what is the problem. So, dear friends, almost most of the question and answers there are. That is, Mr. Mehta sir, can we display the next CME registration?
Yes, sure, sure.
You please be ready. Display it in chat box so that in the meantime
sure.
we can finish that program also.
Yes, yes. Just a moment.
So now we are displaying the next registration link here, chat box. Just click it and finish the activity for next CME. So you need not bother about whole thing. That is one. As regards the very important query that my MSc number is not seen, I can tell you that almost 60% people have succeeded in adding their number that I can see from the screenshots. 40% are not able. That is okay. Don't worry. This is the first CME of this kind, and you don't get nervous. You will be given MMC point, and now focus on the seminar. That is most important. We'll take care of all because we have seen you. We have noted that you are there, and we'll make the whole thing 100%. Okay. What are the other questions? Any questions to Manish Kareka? Because question and answer was not done properly.
Dinka sir, I have posted the details for the 10th webinar.
You have posted in chat box?
Yes, yeah.
So all are requested to open the chat box. You can find yeah. To attend the webinar, register here. That is the line. Click the chat box, see this message, and in the message you have to click only one thing: to attend the webinar, register here. That is sufficient, Mr. Mehta? Clicking?
Yes, yes.
Clicking the is sufficient?
Yes, yes. Everyone will get the details of the webinar and the name of the speakers. Everything is there on that.
Chat box.
Mr. Mehta, is this webinar being recorded?
Yes, yes.
Yeah, because MMC guidelines want us to record this and keep it for at least 6 months.
Yes, it's there. It's there. It will be. It will be there.
Because the MMC guidelines are very clear on this point that we have to record for at least 6 months and keep it. You may call for the recording anytime in the next 6 months.
Yes, it will be there available.
Okay, great. So after the seminar is over, I'm just addressing to all the delegates who are attending today. After the seminar is over, we will be compiling the attendance sheet and submitting it to MMC. So like as Dr. Desai has assured everybody, I would take this to assure all the delegates that they do not worry or panic. The attendance will be duly compiled, and we've got a tremendous help from Mr. Mehta and his team. So they'll be compiling the attendance sheet and we should be submitting it to MMC. And once MMC approves the list, we will be issuing the digital certificates to all. So not to worry, this will happen very smoothly in the next few days, and we'll inform you when the certificates are to be mailed. So like Dr. Desai said, just relax and attend the seminar with a very clear mind. And the same thing will hold true for the 10th seminar also. That webinar also will follow similar guidelines, and we'll be taking care of all the back-end work.
We can even generate the report, attendance report in Excel, and we will mail you. So
yeah.
No need to worry for the participants. We will also give them a screenshots as well as the attendance report. So
Right.
MMC will approve that and will provide the approval.
I'm so sorry, I got disconnected. I'll share my screen right away. Am I audible?
Yes, yes.
Yes.
Vinita? Dr. Vinita?
Sir.
Please wait for some time.
Yes,
People are doing the registration business. Let it be over. I have finished my registration.
Okay, sir.
So we have, in the meantime, we have given some time for registration
Okay,
of
sir.
next CME. So that is going on. Just hold for 1 or 2 minutes.
Okay, sir. Sure, sir.
One more problem of giving the renewal fees, because hardly we had any expenditure because of last 9 months and COVID problem. So we are taking opinion from our chartered accountant whether we can transfer this whole collected money in this year for next year's advance of renewal fee. Then probably we will be in a position to exempt next year's renewal fee. So that is in very serious consideration, and of course, if possible, and the whole thing is all right, then we will be holding definitely a live conference. Resonance. So, have you finished everybody registration? एरे हलवा मला दिसू शकेल. ठीक आहे, नाही जमलं रजिस्ट्रेशन तर मी पुन्हा व्हॉट्सअपवर लिंक पाठवेन आणि तिकडे तुम्ही करू शकाल. एकदा मी सगळ्यांना पाठवणार आहे. आजच्या या सीएमईला नाही म्हटलं तरी एक नवीन 80-85 मेंबर जमले. आणखीन नवीन 20 पॅथॉलॉजिस्ट ज्यांनी मेंबरशिप घेतली नाहीये, 20 ते 25 लोक आहेत जे नुसतेच आपल्याला सीएमई ऐकतायत. त्याच्यामध्ये देर आर पीपल फ्रॉम गुजरात ऑल्सो. There is one lady from Ahmedabad, one person from Navsari. They are attending. So the state association has reached the next adjoining stage. That is a good news. With this, I hand over to Vinita.
Yeah. Am I audible?
Yes, madam.
Yes.
Okay. So I think I got disconnected somewhere here when we were talking about hair follicle tumors. Now, hair follicle tumors, they always look alike. So it is very, very difficult to actually give names to them. So before we start with how to approach them in a very commonsensical way and start naming them, we should know this very basic concept on keratinization. And that is the difference between epidermal keratin, the one that is present in your skin, and the one that is present in hair, which is the pilar keratin. Now, epidermal keratin is the one that has lamellations and has a very, very prominent granular layer. This keratin never ever calcifies. On the other hand, the keratin in your hair, that is amorphous keratin, doesn't have lamellation, doesn't have a prominent granular layer, and that is the keratin which always calcifies. So if you see a hair skin adnexal tumor with calcification, it is most probably a hair follicle tumor. Now, we must actually know the parts of hair follicles and how do they look on histopath, because the tumors that arise from the respective parts, they usually recapitulate the normal structure. So if we know the normal histology of a hair follicle, it would be very easy for us to name the tumors. Now, the hair follicle is basically divided into 4 major parts: the infundibulum, which is your epidermal part, the isthmus, the stem, and your bulb. Now, let's see how they look on histology. So the infundibulum, the one that is there in the epidermis, looks exactly like the epidermis. Okay, so it will have a prominent granular layer. It will have a lamellated keratin, exactly the way the keratin of the epidermis is present. The isthmus, that is the portion which is there in the dermis, the isthmus actually shows the pilar type of keratin, which is amorphous keratin. The lamellations are absent. There is no prominence of granular layer whatsoever. And if you see on the edges, there are these basaloid cells which are kind of arranged in palisades on both sides. Then we come to the stem or the outer root sheath of the hair, which is also called tricholemma. Now, I'm stressing the name of this outer root sheath because the tumors that arise from the stem or the outer root sheath of the hair are called tricholemomas. And they exactly look like the way the actual tricholemma looks. That is, these clear cells. If you see, it is composed of clear cells, very prominent hyalinized basement membrane on both sides. And we'll see how the tumors recapitulate the structure. And then last we come to the hair bulb matrix. The hair bulb matrix, actually, this particular structure that you can see where my pointer is, it is actually called a papillary mesenchymal body. So it is nothing but a cup-shaped structure in which the dermis, the collagen of the dermis invaginates. And if you see, it is made up of basaloid cells with peripheral palisades. So the tumors that arise from the hair bulb, they will recapitulate, they will try to form a similar structure, which looks very, very similar to the hair bulb. So let's see how it is. Now, tumors that arise from the infundibulum, they will show epidermal keratinization. So there are 2 main tumors, trichoadenomas and dilated porovenas. So we have already discussed that they will show epidermal keratinization. So you will see lamellated keratin. So trichoadenoma, adenoma means it will show gland-like structures with lamellated keratin. Dilated porovena, again, if you see, it is nothing but a dilated, one big pore which is dilated and filled with lamellated keratin because it is arising from the infundibular portion. Then tumors that arise from the isthmus. Now we've already discussed that the isthmus shows pilar type of keratinization. So a very, very common tumor that we all see is your tricholemal cyst. So that arises from the isthmic portion, and that is why it shows this type of compact keratin with absence of granular layer, and it mostly calcifies. Then tumors arising from the tricholemma or the outer root sheath are called tricholemomas. And if you see, it actually recapitulates the exact same structure. This is made up of, it's a lobulated structure. Now, the tumor is mostly limited to the dermis, where actually your root sheath is. It is composed of these clear cells, and you can see the prominent basement membrane lining also, which is present in the normal tricholemma as well. And you can just compare and contrast the clear cells here and the clear cells in the normal hair root sheath. Now last we come to the bulb of the hair follicle. Now, tumors that arise from the matrix. Now, before the bulb is the matrix, which is this portion.
tumors which arise from the matrix will show nothing but ghost cells. Now, ghost cells are present in the matrix of the hair follicle, and a very common tumor that arises from the matrix is your pilomatricoma, and it is dominated by the presence of nothing but compact keratinization with presence of a lot of ghost cells. Now, tumors that arise from the bulb would try to recapitulate this dermal papillae. Now, see, if you see, these are the 3 tumors which are showing the bulb differentiation, and they're trying to recapitulate this cup-shaped structure everywhere. So there are 3 main common tumors that arise. That is, one is trichofolliculoma, which shows both follicle plus hair bulb differentiation. You can see there's a central follicle, plus there are these radiating follicles which try and form the papillary mesenchymal bodies. Then the trichoepithelioma, which shows epithelial plus hair bulb differentiation. You can see lamellated keratinous material, which is your epithelial differentiation, plus here basaloid cells forming your dermal papillae. So this is hair bulb differentiation. And then trichoblastoma. Now we all know that any tumor that has a suffix blastoma means it is the most immature tumor. So it is hair, it will show only hair bulb differentiation. So attempting to basaloid cells attempting to form papillary mesenchymal bodies. Trichoblastoma, mind you, is a benign tumor. It's not a malignant tumor. Now, proliferating discussion would be incomplete if we don't discuss about our proliferating tricholemal cyst. Now, what exactly is a proliferating tricholemal cyst? Is it benign or is it malignant? Now, proliferating tricholemal cyst is nothing but a neoplastic version of a tricholemal cyst. It is more often, we all know, seen in women, and usual site is your scalp. It is a tumor of intermediate grade which has a lot of recurrence potential. It ulcerates the overlying skin. It can show cytological atypia. It can show a lot of mitosis. But mitosis and atypia does not signify malignancy per se in a proliferating tricholemal cyst. Stromal invasion is the criteria to call it a malignant tricholemal carcinoma. Okay, so till the time you call it a proliferating tricholemal cyst, it is just a tumor of intermediate grade because they do not actually metastasize. For you to call it a tricholemal carcinoma, you must be able to demonstrate stromal invasion. Okay, and proliferating tricholemal tumors or proliferating tricholemal cysts will always have a pushing border. It doesn't have invasive. If it has invasive, then it is carcinoma now. Okay, and also a very important trivia is that this PTT never arises in a bald scalp. You know, it arises only from terminal hair. And not vellus hair. So you would hardly find, if at all, you would find case reports of them arising from areas of vellus hair like face or hand. It usually arises in scalp or groin or axilla where you have these terminal thick hair. Now we finished hair follicle tumors. Let's come to the eccrine tumors. Now, eccrine tumors also, as the hair follicle tumors, I said, if you know the normal structure and the histology of the normal structure, it will be easier for you to guess the name of the tumor. Similar thing applies to the eccrine tumors as well. Now, if you see here, it's a normal histology of a hair follicle. So here is the glandular portion. Then there is a duct which connects it to the pore. And this is the excretory pore, and the secretions come out through the excretory pore. Tumors that arise from the pore are poromas. So this is your excretory pore, and you can see it is composed of uniform basaloid cells. So your poromas will be connected to the epidermis, and they will be made up of uniform basaloid cells, similar to the normal histology of an eccrine gland. Tumors that arise from the acrosyringum, which is the coil portion, are the eccrine acrospiromas, and the tumors that arise from the secretory ducts and the glands, this thing will be purely dermal tumors. They will not have epidermal connection. So we'll see which are those tumors. Also, now tumors that arise from the secretory duct in the glands. Now let's see the normal secretory duct in the glands. If you see the high bar, you'll see that this is the normal gland, and it contains 2 types of cells. There are cells which have abundant vacuolated cytoplasm, and then there are these cells with very blue nuclei. So there are 2 types of cells, dark cells and light cells, and they are surrounded by a myoepithelial layer. So why am I saying this? Because we'll be discussing which tumors arise from this later. So now first let's come to poroma. So as we discussed, it arises from the excretory pore, which is basaloid completely. So it is the excretory pore is the epidermal portion. So they'll be connected to the epidermis and they'll be composed of uniform basaloid cells. Now, tumors that arise from the secretory part, which has two types of cells, are mainly two, spiroadenomas and cylindromas. They are often called sister tumors. Now, spiroadenomas and cylindromas are usually made up of two types of cells, light and dark cells, because they arise from this part of the gland, which shows light and dark cells. Also, the myoepithelial cells. Now, you may ask, what does the myoepithelial cell do? Now, cylindromas, we all know, are famously known as the tumor with jigsaw puzzle appearance because it shows a prominent eosinophilic matrix around the basaloid tumor islands. Now, this eosinophilic matrix is secreted by your myoepithelial cells. Also, if you see a tumor here, this is nothing but your hello? Hello? Am I audible?
Yes, madam.
Yes. Yes, you are there. You are.
Okay.
Yes, you are.
Okay. So this is nothing, the top portion which is showing tadpole-like cells, this is nothing but a benign mixed tumor of the skin, which we all know. Can anybody name what it is?
Microcystic adnexal carcinoma. Does it look like?
Yeah, and what is the benign version of it? Which is similar to your parotid.
Chondroid syringoma.
Yeah, the chondroid syringoma, yes. So it is called chondroid syringoma because it has a very prominent chondroid matrix, and that chondroid matrix comes from the myoepithelial cells here, which are a part of the duct. It recapitulates these ductal, exactly the duct-like structures because it is formed from the ducts. Now, the tumor that arises from the acrosyringum, I've placed it separately because there is a lot of debate on the cell of origin. And acrosyringum, the tumor that arises, is also called hidradenoma. Now, these tumors may show epidermal attachment. Half of them show and half of them don't show. And they're usually composed of three types of cells: basaloid, squamoid, and clear cells. Now, some practical points and tips that you must always remember is that eccrine tumors will never show you calcification unless they are very, very old and they are very big. So if you see calcification in a skin adnexal tumor, you are probably dealing with a hair follicle tumor. Some tumors have special predilection for a site. For example, poromas usually arise in palms and soles. If they say scalp, you're probably dealing with cylindromas or acrospiromas. Or if you look at hair for adnexal tumors, then your tricholemal cysts, proliferating tricholemal cysts. Spiroadenomas are another tumors that are painful. So if you have a skin adnexal tumor that is painful and showing you two types of cells with infiltration of lymphocytes, a dermal tumor, it is probably spiroadenoma. Also, spiroadenomas, one thing is very, very common in spiroadenomas is that they are very vascular. They can become really large and they can excoriate or ulcerate the overlying skin. But that is not a sign of malignancy. That alone is not a sign of malignancy. Okay. Another thing is spiroadenomas and hidradenomas can be markedly cystic. So if you have a cystic adnexal tumors, then these two are your first differentials. Chondroid syringoma, whenever you see a chondroid syringoma, make sure that you always have the base of the tumor and it shows circumscription. Rule out any infiltration and beware of microcystic adnexal carcinomas because microcystic adnexal carcinomas can look very, very naive and benign, and you have to really look for the circumscription of the tumor. Okay, so when you deal with eccrine tumors, there are only three questions that you should answer and go on this order. First is, does it have an epidermal connection? Second is, does it have monotonous cell population or more than cell population? And third is, does it have a specific pattern? So epidermal connection is poromas and acrospiromas. Monotonous cell population, again, your poromas. And if it has more than one cell population that we know are the tumors that arise from the ductal portion, that is your spiroadenomas, your cylindromas, your acrospiromas. And does it have a specific pattern? For example, jigsaw puzzle pattern in case of your cylindromas. Microcystic adnexal carcinomas show those typical duct-like structures or tadpole structures. And then your spiroadenomas can have prominent lymphocytic features. The last is sebaceous tumors. There's not much in sebaceous tumors to be discussed. So the only thing that is usually bothers in a sebaceous tumor is distinction between sebaceous hyperplasia, sebasioma, and sebaceous adenoma. Now what to do? So look at sebaceous hyperplasia. If it recapitulates, if there is only a single layer of basaloid cells in the periphery, which is just recapitulating your normal sebaceous glands, it is probably just a sebaceous hyperplasia. In sebasioma and sebaceous adenoma, how do you differentiate? In both of these tumors, there is increase in basaloid cells within the lobules. If the number of basaloid cells is less than 50%, it is sebaceous adenoma. That is, you have more sebocytes. And if you have more basaloid cells and it looks very blue, then it is sebasioma. Now, basaloid cells, always beware, which we have discussed. Basaloid cells in sebasioma may show brisk mitosis and sibilate carcinoma, but brisk mitosis and sebasioma do not please bother unless you see atypical. And holocrine secretions always differentiated from necrosis. Now, this is another tumor of apocrine tumors are very, very least common, and I have just included them in case-wise manner. So this is 34 female vulval tumor. It's a very, very typical tumor. Anyone can attempt? Anyone can? Okay, so this is hidradenoma papilliferum, and it is a typical. It has a typical H&E appearance. Another tumor which shows apocrine differentiation and partly ecrine differentiation is, and it is typically a tumor on the scalp in young teenage boys, is this. So this is your syringocystadenoma papilliferum. These are the two apocrine tumors. Now the summary, I'll just sum up my talk. So the summary is, first is benign versus malignant, and that is the most important part of your report. So even if you have done this benign versus malignant clearly, your report is correct. If you come to step 2 and 3, then good enough. But even step 1 is fine. And that is the most important step, believe me. So ecrine differentiation, if you see cells with basaloid appearance, duct-like structures, clear and dark, mixture of clear and dark cells, and eosinophilic matrix lining those dark cells, you're probably dealing with ecrine differentiation. So duct-like structures is the main thing to look for in ecrine differentiation. That gives you the clue. For hair follicle differentiation, if you see basaloid cells, but with prominent peripheral palisades, trichilemmal type of keratinization, ghost cells, papillary mesenchymal bodies, we've already discussed what those are, and very clear cells, glycogen-rich cells, which are seen in your trichilemomas. So those are clues to your hair follicle differentiation. And sebaceous, we all can very, very easily recognize. The only problem with sebaceous is not to fall in trap of benign versus malignant. Now, IHC actually is very rarely done in skin adnexal tumors, only to differentiate between BCC and some hair follicle tumors, which may simulate BCC. Now,
950 charge kiya?
So it is the markers that you can use are BCL2, CD10, and CD34. Many people may not be doing it, but I'll just quickly summarize that in BCC, you'll have a diffuse BCL2 expression in the epithelium because they're neoplastic cells, and BCL2 is nothing but an anti-apoptotic marker. So they are not undergoing apoptosis. That means they're neoplastic. So in BCC, epithelial cells will show diffuse staining, whereas in hair follicle tumors, for example, a trichoepithelioma, which closely mimics a BCC, only the outer layer will show you BCL2 expression, which is a germinative layer. Otherwise, it will be absent. And CD10 again will be positive in BCC, but negative in trichoepitheliomas. The next slide just shows, because we all know that skin adnexal tumors are associated with tumor syndrome. So this is a very theoretical point, which is there in each and every book. So there are only two take-home messages that I want to say, and which we always have to remember. First is, make low PAR your best friend. So always start with low PAR and spend maximum time at it. So bird's eye view is always better than the worm's eye view. And second is a tumor that looks benign may not be benign. Okay, and vice versa also. So always pay attention to these two things. And with this, I have come to the end of my talk. Thank you so much for listening patiently.
That was, in fact, a wonderful presentation, Dr. Vinita.
Thank you, sir.
In fact, you have shown us the way to diagnose skin adnexal tumors. Actually, diagnosing skin tumors are very difficult. But from now on, we'll be able to diagnose it very fast and very quickly. Thank you for guiding us.
Thank you, sir. My pleasure.
आदित्य माझा व्हिडिओ चालू करा. आदित्य,
you can turn on your video by yourself.
नाही होत नाहीये. होस्ट स्टॉप रेट येते. ओके, थँक यू. Dr. Vaishali Kale?
Yes, sir.
You are there. Your video is also. Just a minute. You please wait for 1 minute. We'll take a photograph. Please put on your videos. Hello. Everybody, see that your video is on. Dr. Sarup, can you take the photographs? Screen चा घ्यायचा आणि उजव्या बाजूला हे करायचं. There are 4 screens. घेऊन तुझ्याकडेच ठेव. Dr. Kale, you start your video. Lalit also, you start your video. Lalit, video चालू करा.
Thank you.
काही लोक झोपलेत का काय? बापरे, इकडे तर बरेच व्हिडिओ बनले. व्हिडिओ चालू करा. फोटो घेतायत. नंतर म्हणू नका आम्ही होतो म्हणून. एक मिनिट. वेबिनार म्हणजे आम्हाला कटकटच आहे ऑर्गनायझेशन. प्रॉब्लेम काय, जरा जरी मिस्टेक झाली तर आपलं सगळंच रद्द होईल. राहुल पांडे इज नॉट देअर.
Sir, I am there.
तुमचा व्हिडिओ चालू नाहीये. व्हिडिओ चालू करा ना सगळे. व्हिडिओ इज नॉट देअर. मोना H video is not on.
I think
Aniruddha Randive, Ashwini Sahasrabudhe, video is not on. व्हिडिओ चालू करा. तुम्ही दिसले पाहिजे ना फोटो मध्ये. असं काय झोपले की काय सगळे लोक? एवढं सेडेटिव्ह लेक्चर असतं.
व्हिडिओ कसं चालू करायचं तेच नाही.
इकडे ललित तर खुश होऊन गेला लेक्चरर. ठीक आहे, दिसतात तेवढेच घेतो आता. का जितेंद्र खेडकर, सुचिता, सुबोध इज देअर. सुबोधने काय लिहिलंय? सुबोध कसा आला? अश्विनी सहस्रबुद्धे.
नंबर क्या रहेगा?
मनीष अखरे. मनीष, you are newcomer. We welcome all the newcomers, sir. There are 82.
अरे वो वीडियो चालू कैसे करने का है?
व्हिडिओ चालू करायला खाली डावीकडे स्टॉप व्हिडिओ, स्टार्ट व्हिडिओ असतो, तिकडे करा.
Start video, stop video is there.
So your voice is recorded, madam. Archana madam. Now you don't bother about certificate.
We should go ahead.
I think they will continue the CME now.
And genuinely attending the CME, huh?
Sir, I think let us continue the CME.
नाही, एवढा एक फोटोग्राफ घ्या ना. अरे जरा पटपट या ना. हे काय आहे? डिंपल खटपल, किरीन बेंडाळे, बलराज राठोड, तेजस्वती धोटे, कुठे आहे तुम्ही लोक? राजेंद्र पाटील, देविका धाबे, अमृता जोशी जे न्यू मेंबर, शी फ्रॉम मेट्रोपोलिस. अरे काय चित्रा नेतारे आले का? चला पुढे कोण आहे? Minal?
Yeah, I'll introduce, sir. Am I audible?
Yeah, just wait 1 second.
Why am I not seeing to myself?
देखो मेरा वीडियो वहाँ पे चालू है, वहाँ पे मेरा वो वाला फोटो आ रहा है, जीमेल का फोटो आ रहा है.
चलो आदित्य सर.
You'll have to ping yourself.
Mr. Aditya, we are continuing.
Done, na?
Done.
Thank you.
Hello.
Hello, I am audible.
Yeah.
Should we start, sir?
Yes. Hello.
Sir, should we
Yes,
start?
ma'am. Go ahead.
Yeah, let's
Yeah.
start.
I hope everyone is alert and awake. Good evening, everyone. Wishing you all a very happy and healthy new year. Let me introduce our young speaker from Latur. He is Dr. Rupesh Gundawar. He did his MD Pathology from Topiwala National Medical College and Nair Hospital, Mumbai in 2014. He worked as an assistant professor at GMC Latur and was also a consultant histopathologist at Golwilkar Metropolis, Pune. Yes, histopathology is his passion, and since 2017, he has been associated with and is co-director of Krishna Surgical Pathology, Latur. It's the only exclusive surgical pathology lab in the region of Marathwada. He has special interest in IHC and has been running the first in-house IHC lab in Marathwada region for last 3 years. More interestingly, and to benefit of everyone, he has started online teaching platform HistoLearn along with our previous speaker, Dr. Vinita Pandey, and not only PG students, but also many practicing pathologists are following it and their webinar activities. So that's really very commendable. Sir, should I also introduce Anupama right away? Hello, sir.
Yes.
Okay. Our another speaker, I don't think I need to introduce her. She's so active member of our TPA group, and she's a Thaneite and a friend of mine. She's from Ulhasnagar, Dr. Anupama Verma. I really don't have to introduce her, but I need to complete the formality. She passed her MBBS and MD Pathology from GMC Nagpur in 1996. Post-MD, she was an assistant professor at GMC Mumbai for 3 years. Also gathered experience from prestigious Tata Memorial Hospital. In 1999, she established her own setup at Ulhasnagar and Dombivli. Her special interest is in the field of oncology, thalassemia, HIV, and tuberculosis. She was attached to Thalassemia Foundation for 15 years and is on the board of government HIV project NACO. Even during COVID time, she contributed to society by imparting knowledge on COVID for common man via YouTube and other media. So over to very dynamic and enthusiastic speakers of today's CME, Dr. Rupesh and Dr. Anupama.
Thank you for the introduction, ma'am. I think this slide seminar is nothing but to have the visual examples of what have been told by Dr. Vinita in the previous lecture. So we will start with our cases. First case is a 40-year male who is having nodular growth over the skull, and this is the section of that tumor. I will share my screen. Just confirm that whether my microscope is visible or not, and then Dr. Anupama will have the description. So I think everyone can see the microscope, right? Just confirm. Yeah. Okay, fine. I will move the slides then. So this is the first case. Anupama ma'am, can you start?
Yeah, am I audible?
Yes.
Yes, yes, yes.
Good afternoon, everyone. It's a pleasure to be on TPA platform and share a slide seminar with Dr. Rupesh, who is really knowledgeable. And after a overview by and lecture by Dr. Vinita, it's very easy to describe, but I'm just going to repeat what she has taught us actually. So under scanner view, we have to observe.
दिनकर नहीं बोला तू नहीं बोल रहा है इसके लिए
Under scanner view, we have to
मैं
observe.
कहाँ देखा यार
Somebody is interrupting, I think.
Hello, am I audible?
Yes, yes, ma'am. Go ahead.
Yeah. So as you can see under scanner view, there are two kind of population, and our histopathology teacher at Nagpur used to tell ki you have to describe in the form of HND. Kitna pink dikh raha hai, kitna blue dikh raha hai. So I'm going to repeat the same thing. Just see how many areas is showing pink and blue. Is showing both kind of population, pink and blue. That is eosinophilic and basophilic areas. Now, can we see the overlying skin, Dr. Rupesh?
No,
This
actually,
is the
if you
complete
can
region.
see, this is the lower part of the tumor, and it looks to be circumscribed. I
Okay.
will go on the 10x.
Yeah.
So that way we can guess this could
So
be
I'm not going to tell.
excised.
Don't tell. I'm not going to tell the diagnosis. The thing is, it is a spotter. During our MD time, this slide was kept. It is a spotter. It's showing. I'm just giving 3 lines. It's showing two kind of population: blue population and pink population, and something is related to ghost. Can anybody guess?
Pilometric.
Correct. So all are passed. Okay. So it's I'm just going to describe few things about it. Under scanner, it shows two kind of population. In high power, it's showing you basophilic cells, which we call baseloid cells. What are baseloid cells? These are cells which resemble basal cells of the epidermis. So they are basal cells. They are small cells, cuboidal cells, having high NC ratio as compared to squamous cells, and it is showing benign, monomorphic, ovoid nuclei. And now you just see the transition in it is a evolving lesion. It is seen in young adults. So the important thing is in the periphery you can see the blue cells, which are baseloid cells. As the lesion evolves, gets mature towards the center of the lesion, which Dr. Rupesh is focusing, it is getting more and more pink. Slowly the cell is getting enlarged and the nuclei are getting um, uh, disappearing. So the cells which are on the center, they are having a clear gap in the center. That is, the nuclei have gone, so they have become ghost. Therefore, it is called ghost cells. Or you can see the shadow of nuclei in the center of those squamous cells. Therefore, they are also called shadow cells. Can you see the clear? Dr. Rupesh, can you focus on classical? Yeah, you can see the squamous cells which are intermingling with each other, and you can see the clear gap, and that gap is actually shadow of the dead nuclei. Therefore, they are also called shadow cells. So it is the lesion of having moderate longevity. It is not new, it is not very old. Slowly, as the lesion progresses, as the age of patient increases and lesion progresses, slowly most of the blue areas will be replaced by pink areas. So those basaloid cells will be replaced by more and more pink areas, and in later stages, um, it can show calcification. And most of the slides which I have seen the areas under low power. You can see the areas of calcification. You can see biomorphic population, blue cells and pink cells, and around the calcification you can see foreign body giant cells. In this particular case, calcification is not seen, but the diagnostic feature is basaloid cells and the shadow cells. Dr. Rupesh, you want to add something, please?
Nothing. I think every part has been covered. I just want to show, as in previous lecture it was told, कि adnexal tumor generally recapitulates their normal anatomy. So as this is a pilomatricoma is a tumor of matrical differentiation, that is hair matrix. So somewhere you can just see, or at least you can just outline, like here some hair follicle is going through this center.
Yes.
And whatever tumor is proliferating, it is proliferating around that. So just a finding to note that it is a tumor of hair follicular differentiation with matrical differentiation. And yes, as said,
that the common DD is matricoma. I couldn't find something. If you can highlight that.
See, matricoma, actually, there will be 2 or 3 opinions whether we should separately label something as a matricoma, or is it actually different from pilomatricoma. I think matricoma or pilomatricoma is more of the same kind of tumor. In the previous, in older literature, you will see the 2 nomenclature used differently, but in newer nomenclature, the theory that these being 2 different tumor has been questioned. So this is nothing but a single type of tumor.
बाकी मैंने पीछे के सब देखे हैं वो देख.
So is it okay? Can we move on the second case?
Second case, please.
Okay, so now second case is a case of 50-year male having long-standing swelling.
Rupesh, sorry to interrupt you. Anytime did you see a case of proliferating pilomatricoma?
No, not exactly. Means proliferating pilomatricoma, some other features should be seen, like the some kind of nuclear atypia or mitosis. And yeah, as in skin adnexal tumor, getting some small focus of necrosis is also not worrisome. So in such cases, those tumor can be labeled as a proliferating pilomatricoma, which do not completely meets the criteria of a malignant pilomatricoma, like necrosis with apoptosis or atypical mitosis and infiltrating nature of the tumor in the surrounding stroma. So this is just like a in between the pilomatricoma and a malignant pilomatricoma.
Okay. Basically, I had come across one case where I had actually I had taken an opinion. So where they said it's a proliferating pilomatricoma. Basically, used to see large solid and cystic basaloid cell areas with very few areas of shadow cells. So in fact, I was also very much confused. Then I took an opinion. Then it was termed as proliferating pilomatricoma actually. And the patient was of middle age, basically middle to like around 50s or something like that.
Okay.
Anyways,
anyway, pilomatricoma are generally seen in towards mid and lower age only, not so common in pediatric age.
Right. Okay.
Fine. So next case is of a long-standing swelling on lateral aspect of right elbow, and it was painful. So excision was done. On excision, what we received were the multiple nodules, which were looking circumscribed. So I will just describe the lesion and will also show it. So, okay, I think on scanner view, even you can also notice that there are more than one nodular areas. Even a circumscription can be noted properly. Okay, this is like a lower outer edge of one of the nodule and this is of this another. So this is kind of a multinodular tumor. And as I'm going through all areas, skin is nowhere seen, okay? And these nodules are seen surrounded by the fat. So as we are having a skin adnexal tumor, this has to be subcutaneous fat. Some cystic appearance can be noted. But most of the nodules, these are circumscribed. If I go on high power,
Rupesh, your screen cannot be seen.
sorry?
Rupesh, your screen cannot be seen.
Let me check. Screen is not seen?
It is not seen.
I am able to see.
I'm able to see.
I am able to see.
Yeah, we can see.
Okay, then I think I can proceed, right?
Yeah.
So I'm going on 20x view. You can see this is like a connecting anastomas in cords and trabeculae with intervening fibrovascular stroma. All these cords and trabeculae these are showing kind of two types of cells, right? The outer cells are kind of basophilic, having the hyperchromatic nuclei, and the inner cells, they are bit vesicular, like one can say, but having some sort of appreciable amount of cytoplasm. So they are paler than the peripheral cells. Okay, so this is kind of two types of population. So just to get the answer, I am just repeating the findings. The circumscribed nodule, no skin above is noted. That means it is a dermal based tumor or low, or in deep in the subcutis. Two population of cells in anastomosing pattern. And if we see, even a duct formation is also appreciable. So can we have answer?
You had given a point in history also.
Yes, history is also point having a clue for this diagnosis.
What
Should I
is the
wait for the answer?
site of the tumor?
This is on the right elbow. Extensor
Okay.
aspect. So first thing, if you can see the duct formation that I showed here, that means it is a tumor of some apocrine or ecrine category, right? Then I couldn't show you the epidermis. That means it has no connection to epidermis. So that way your differential again gets narrowed. Thirdly, there is population of there is two cell population can be seen. And fourthly, the tumor is tender. Tumor was painful. So I think it is enough to have the diagnosis. I will just go through the other areas. And another finding is, you can see the third type of cells are also evident. These are the small lymphocytes. Okay, here you can see the pale cells, the basophilic cells, and then the sprinkling of these lymphocytes. Okay, so as I showed you the duct formation, this has to be definitely a tumor of ecrine apocrine origin. Two types of cell population with total dermal based tumor. That means it is a spiroadenoma. Okay, so the diagnosis is spiroadenoma. Two characteristic features are, one is like a uniform sprinkling by the lymphocytes. You will get that frequently in all types of spiroadenoma. And another finding why it is tender, because many of the spiroadenoma will show you the telangiectatic pattern. That is the dilated vascular pattern is the prominent finding. You can see here these telangiectatic spaces, and even these are filled with some fibrin. So the tumors which have prominent angio component, they will be clinically painful and tender. So this is one more finding in this spiroadenoma. I'm just showing the telangiectatic area, the dilated and blood-filled spaces. Okay, so this is.
I think this is Rupesh, I think this is the only tumor where we see lymphocytes in skin adnexal tumor.
Sorry.
Or any other tumor. This is the only tumor where we see lymphocytes.
This makes the characteristic finding in spiroadenoma. See, lymphocyte, having the lymphocyte population, it is like a host response to the tumor. Okay, but in spiroadenoma, it is very, very characteristic. You will see this uniform sprinkling as if it is forming a prominent component of that tumor rather than the passenger cells. So the third case was a swelling over nose in an old female. I hope I am not going too fast. So, okay. So now, as Vinita told us, in any tumor, when it is skin adnexal or skin adnexal tumor, you first have to see whether it is benign or malignant. So this is a scanner view. I can cover whole of the lesion, and you can see the shoulder of this lesion. Okay. So the adnexal, adjacent adnexal to one end and adnexal to the other end. So this tumor has proper shoulder. Then the lower border is lobulated, well formed. Okay. It is not infiltrating. So this is like, so this confirms that we are dealing with some benign tumor.
Benign tumor.
And then the epidermal attachment can be seen here. Okay, so then we have to remember which are the tumors which have epidermal attachment. Okay, then a lobular. So the third part now towards the morphology. A lobulated tumor, uniform cells with baseloid appearance, scant basophilic cytoplasm, basophilic cytoplasm, round nuclei and prominent nucleoli. Then these areas of clear cells. I think I should not name it. These are telling themselves what are they, right? So the lobules of baseloid cells with some differentiation towards clear cells. Clear means that is not actually clear. These are having the bubbly cytoplasm. So I will again show a low power view. And I think there is nothing much to describe in the lesion to have the diagnosis. So can anyone diagnose or at least tell which kind of tumor it is, means of which category?
Is it a hydroadenoma?
Okay. See, if I want to show you hydroadenoma, I would have shown you some duct formation, right? I didn't show you that because it is not there. So I think that is ruled out. Can you just make out what these clear cells are? This clear cell itself is a clue for the diagnosis. Somewhere this squamar differentiation can also be seen, but I think we can omit this for a while. Do we have diagnosis from the viewers, like in the chat box? So, okay, these clear cells are nothing but the sebocytes. Okay, so when I say these sebocytes, that means these are the baseloid cells which are not transformed into the mature sebocytes. So, okay, so this is a tumor of sebaceous differentiation. See here, the epidermal attachment can be seen. And then the clear cells are less in population than the baseloid cells. So this is a case of sebaceoma. Had this been a cell tumor with more clear sebocytes than the baseloid cells, I would have labeled it as a sebaceous adenoma. So that is just the criteria to name either a sebaceoma or sebaceous adenoma. Any confusion in this case or? Can I go to next case? Okay. So next case is case of 40-year female. She was having growth over right cheek. So I will go step by step, or I think for this case, Anupama madam can take over.
Yeah. Dr. Rupesh, can you focus epidermis like it was taught by Dr. Vinita? Can we see the epidermis? Yes. So as she told that we have to at least 80% diagnosis should be ready by the scanner view. So first we have to see whether it is connected to epidermis or it is intraepidermal or it is epidermal and intraepidermal both or it is completely dermal. So as we can see, the tumor is very much away from the epidermis and there is a clear grain zone between. Can you mark it? There is a clear zone.
Actually, this
here
tumor
it is in this
is attached.
grain zone actually.
Is attached to tumor.
Okay.
It's attached to the
attached.
epidermis.
Okay. So yeah, that you are showing, I think. Okay. So here it is attached. So it is having both the components. That is it is attached to epidermis and it is having pure dermal component also. It is having both the component. And now it is showing very well circumscribed kind of tumor mass and kind of pushing kind of margins as if it is pushing into the dermis. Most of the part is in the dermis. Basically, a dermal tumor with the epidermal attachment. Then there is a shouldering which she was describing, Dr. Vinita. On both the sides of the lesion, there is a presence of adnexal structure, as if the tumor was pressing on both sides to the adnexal structure. So there is shouldering is seen. So it is looking like a benign tumor with the main area in the dermal area, and it is having at places epidermal connection. Now, if you go to the more higher power, it is showing the remaining the nodules in the form of nodules. There are well-defined nodules, solid nodules, and there is a thin zone of stromal tissue in between. At places, there are cystic structures also, which are filled with homogeneous pink material. I think we should go to higher power now to know what it is, type of cells. Now, in this power, we can see two kind of cells. Some cells are clear, and some cells are having eosinophilic cytoplasm, more kind of spermoid or polyhedral cells with eosinophilic cytoplasm. And clear cells are very prominent. Around 30 to 40% cells are of clear cells. And Dr. Rupesh just focused that area where cystic component is also there. Yeah, this is a cystic component. So this tumor is also known to have prominent cystic. Clinically also, cystic component can be prominent. Clinician can tell you it is partly cystic, partly solid. That also can take you to the guess. And there are some tubular lumina are present, some clear spaces poorly formed, and that also points towards the lineage which Dr. Vinita was telling and Dr. Rupesh was telling. So that tubular lumina, can you focus more on lumina for the public? Yeah, see, this is the small spaces, tubular lumina. And one thing which I was reading yesterday, this tubular lumina can be extra cellular, that is, it is formed outside the cells, so it is in between the two cells, and sometimes it is formed within the cells, which is we call intra cytoplasmic lumina, which gives rise to the vacuolation. So this points towards the lineage. I think that lineage is acrine. There are squamous eddies also forms. These whorls are seen. Can you point out, Dr. Rupesh? These are squamous eddies we call, or whirling pattern, or onion skin pattern you can call it. So there are two kind of cell population. One is clear cell, and other is polyhedral cell, which more kind of eosinophil cytoplasm. Second thing is it is mainly dermal kind of thing. Third, it is attached to the epidermis at one few places, and there are this tubular structure. I think this is very classical case. I don't want to name that. Please name it. Someone. It's as if Dr. Vinita was describing and Dr. Rupesh is showing. So I don't want to tell the diagnosis. Anybody?
I think we may have answer from other people who cannot actually speak. Means in question
Okay.
and answer they might have answered us.
Okay, so it's basically hydradenoma, and it is
जिसके यार
called nodular
क्या बोलते
hydradenoma.
हैं
Yeah, somebody told. Dr. Rupesh, you want to add something? Please add.
Generally, hydradenoma is a completely dermal based tumor, but that is not actually the rule. Means now you see here, as we told you before, hydradenoma is generally a dermal based tumor, but here you can see the epidermal attachment, but that just doesn't preclude the diagnosis. The characteristic finding is actually ideally this is having a three types of population of cells. Two cells predominant, that is clear cells, and the eosinophilic polyhedral cells, and the other cells are the squamoid cells, which are forming the squamous eddies that I showed you. So this is kind of a population of, means it is tumor of three types of cells, and then formation of duct tells that it is a ecrine apocrine differentiation. Three cell population, ecrine apocrine differentiation, and generally a dermal based tumor, so it has to be nodular hydradenoma. See, you want to label this as a nodular hydradenoma, clear cell hydradenoma, or nodulocystic hydradenoma, it's your choice. That doesn't make any difference. So this is a case of hydradenoma.
One thing I wanted to add, don't think that hydradenoma is always acrine. It can be of apocrine lineage also. One thing. Another thing is location also. It can be Purely dermal and attachment to epidermis. That I wanted to add.
Yes, that is what ecrine and apocrine tumor, they have too many overlaps between them. Means a tumor which is ideally looking like ecrine can show you apocrine feature. That's why they are classified under the group of tumors of ecrine/apocrine differentiation.
Yes. That I wanted to add.
Yeah, one more.
Okay, the next case.
Rupesh, I wanted to add, sometimes we do see mucinous cells also in hydroadenoma, but they are less common actually. Predominantly we see only clear cells and all this.
Polyhedral cells and then those squamoid cells.
Yes.
Okay, so the next case is a scalp swelling. It was there since 2 years in a 45-year female. So just go with the rule. Can we see the epidermal anywhere? I think no epidermis seen, but you can see the lower base of the tumor. This shows that it is kind of circumscribed. See, the adjacent adnexia can be seen over here. So that means this tumor could be excised without compromising the skin. So overall tumor is showing the widely anastomosing or syncytial, one can say syncytial types of lobules and trabeculae. Acellular eosinophilic material. I am highlighting that acellular eosinophilic material, and this area properly shows you that it is getting produced from these cells. The cells here are having the abundant eosinophilic pale type of cytoplasm. You can actually make out the intracellular spaces, what we usually see in the squamous type of tumor. So this is the intratumoral stroma. Calcification can be noted. And the giant cell reaction.
You are mentioning all the points towards diagnosis.
Yes, because I am expecting it from the audience.
All the terms like the examiner prompts, no, those words you are using.
See, the squamous ADs means I think you can clearly make out this has squamous loop, but in squamous tumor we generally get a parakeratotic type of keratin, that is a lamellated keratin, but here it is acellular keratin showing the calcification. So when you see a calcification and acellular keratin, there it has to be a kind of tumor that already Vinita told us. So at least this tells you that this is a kind of a follicular cell tumor. Okay, the location is scalp. And even if it is benign, at least it is not showing the extratumoral irregular infiltration, but within the tumor, it has very lobular and proliferating look.
Is it a proliferating tricholemal type tumor?
Right. This is a proliferating tricholemal tumor. That is a pilar tumor, we can also say.
Okay.
No necrosis as such. Okay, this is all the pilar type of keratin and not the necrosis. Stroma is abundant, but there is no as such means adverse stromal reaction. No atypia as such, means no pleomorphism or even mitosis cannot be seen. So yeah, this is a proliferating pilar tumor. I showed you the outer circumscription. Yes, means the overall, if you see the overall look, it looks grave. Means one may get prompted to say it as some malignant tumor or something like that. But when you go on higher power, you won't get that pleomorphism to say something as a malignancy.
Right.
That's why it is this is one of the section of the tumor. It is very important to see the peripheral shouldering or any epidermal attachment or any other features. So these are lacking over here. So this is a proliferating pilar tumor. And the next case, the case of a fungating growth over the chest wall in an old age male. So just go with the rules. Tumor is attached to the epidermis and which has got ulcerated. I am just showing the age of attachment. I think. See the epidermis, tumor is attached to it, and then there is marked ulceration of this on the surface. Okay. Now just compare with the previous thing. The cytoplasm is definitely towards lesser amount than the previous what we see. Okay. Nuclei are showing some pleomorphism. You can properly see the mitosis. I need not highlight them. Even this one focus is showing you too many mitosis. Just compare the nuclear atypia.
But overall, the cell population looks monotonous.
And see the lower, say, okay, this is one of the age of the tumor. But now see here, it's the lower age is not lobulated. In all previous cases, we see the proper circumscription towards the base, but see here, it is infiltrating in the lower stroma, in adjacent stroma. The lower side of tumor is not smooth, right? See, is infiltrating through and in between the erector muscle, right?
Oh, pure.
And I think mitosis are evident. You cannot miss these many mitosis.
There is necrosis within the tumor, apart from the surface?
Let me check. I think it has to be,
Dr. Vinita was telling that surface excoriation is very common. So yeah.
Yes, surface excoriation is common. When tumor is benign, but for many years or months, it may be pushing the epidermis and then it may cause the ulceration of that. But here, this is intratumoral necrosis.
Yes,
Too many mitosis and.
And can you focus nuclear dust which you were talking?
Let me see.
Or it is just a keratin, amorphous keratin that we wanted to differentiate them.
I think in this slide it might not be there, but I think this focus is showing the infiltrating nature of the tumor, right? The lobules are getting detached and infiltrating in the surrounding stroma. So can anyone label this?
Benign or malignant?
I think I should not expect answer in this case because the characteristic finding in this case was that there was a pilar type of keratination present, but in that slide the other findings were not there. So I labeled this case as a trichilemmal carcinoma. I can show you the pilar type of keratination here. Too much background noise is there. I think someone is driving and then watching this seminar. See, this focus tells you the pilar type of keratination, right? So this pilar type of keratination at least tells you that this is a pilar follicular tumor. In the center, you can notice the clear cytoplasm of these cells, which is getting squamatized laterally or centrifugally. So at least with these features, even if you can say that this is a malignant adnexal tumor with follicular differentiation, that is enough. Then to label this as a trichilemmal carcinoma or something, the other type of carcinoma doesn't matter that much. Do I need to show this case still, or I can move to the next case?
I think that is sufficient area.
I think you can move ahead.
Right. So next case is 85-year male. That nodular lesion was seen on the left great toe. It was pigmented, so clinically it was suspected to be a melanoma. Ma'am, give me a break. You describe this lesion now.
Yeah, okay, thank you. Uh, can you show me the upper epidermis first, like we were taught? Go to the margin and where, yeah, we can see the epidermis. So tumor is connected to the epidermis and lot of keratinized material, laminated keratin is there on the surface of tumor. And can we go deep? Yeah, we will need scanner view. In scanner view, we can see there are some trabeculas are traveling from the epidermis into the dermis. Yeah, here you can see that it is that the mass is attached to the overlying epidermis. That is one point, and there are broad bands which are going inside. Can you show? Yeah, it's going inside. And one thing which will excite many viewers that there is that cleft formation around the tumor mass. So somebody must be thinking some in some lines, but please wait, don't jump. Uh, See, there are clear gaps. There is stromal clefting, which Dr. Veena was telling, tumor versus stroma is there. If you are thinking of BCC or basal cell carcinoma, just see there is no peripheral palisading. So again, we can go to scanner view, please, because I want to describe from scanner view. So it is showing wide, broad bands going from the epidermis into the dermis. Within the dermis, there are broad white nodules are there, and in the lower margin is very much well defined, and it's kind of pushing things. There are no small nodules going inside in irregular manner. And the lower border is very much well defined, and the borders are pushing kind of thing, as if it's pushing to the normal. So it's looking like benign. That is what I am thinking, and I think he wants to show the shouldering. Am I right, doctor?
No, actually, I'm just showing in this focus the epidermal attachment and then the tongues of tumor cells going
Yeah.
into the dermis.
Something is going from the epidermis into the dermis. So it is having epidermal as well as dermal component, first thing. And the borders are pushing kind of and inflammation. Now we are going on the higher power. Just try to focus on the type of cells, whether it's single population or double population. What I am perceiving, it is looking like a single population, and those cells are actually monomorphic, same kind of cells. And other thing is the nuclei are ratio is high NC ratio. Cytoplasm is less, it's more kind of blue kind of thing, and the nuclei are ovoid, central, and in this power I'm not seeing any mitosis, so I'm more thinking on the line of benign, first thing. Second, the type of cell, it is looking like monomorphic cell. And one thing which Dr. Vinita was telling and Dr. Rupesh was also telling, that these cells are looking like basaloid, but they are not basaloid because in high power there are intercellular bridges are seen. Means it's looking like small kind of a squamous cell, small kind of squamous cell. So it is a cell which is going towards squamous, like she was telling, towards the pore, some attachment was there. So I'm thinking more of kind of poroma. The third thing also, which is supporting, there are some tubular lamina, tubular. Can you show some? And there are some cystic spaces also, and fine, very narrow tubular lamina is also there. And once I will describe that, I will describe, even if I'm thinking of poroma, it's not just because it is having both a component, epidermal as well as dermal, because there are purely intraepidermal poromas also, which we will describe later. And there are purely dermal kind of poromas, the poroid tumors also, poroid tumors. But for poroma to be tumor called to be a poroma, the tumor is having poroid cells, the cells which I described, monomorphic small cells, high NC ratio as compared to the normal squamous cells, and those cells on high power. They now he's focusing the tubules, small tubules, clear space in between the so it's form kind of acrine, what you want to say. So for me it is looking like poroma, because the broad bands, I'm just sum up all the findings. It is having epidermal connection. there are broad anastomosing cords of cells which are coming from the epidermis going into the dermis. Then there is monomorphic population. Then there are tubule formation, and those cells are looking not like a basophilic cell or baseloid cell. It is basically poroid cell. Why? Because they are looking like baseloid, but on high power they are showing intercellular bridges. It's basically small kind of squamous epithelial cell that I wanted to stress. And anything else? And I know I wanted to add, if it is there, it's just because it is having poroid cells. There are other kind of poroid tumor also, which are purely intraepidermal, and there are purely dermal poroid tumor also. But the tumor which are having poroid cells having both the components going from the epidermis going into the dermis with broad anastomosing kind of picture, and no peripheral palisading. Here it is seen stromal clefting around the tumor nodules, but it is not showing palisading. So it is, for me, it is poroma. I think I have
I
described.
agree.
You want to add something, Dr. Rupesh? I have left.
See, getting these many clefts can tempt someone to think towards the line of basal cell carcinoma. So the stromal clefting is not just limited to basal cell carcinoma. Then you need to see whether the peripheral palisading is there or not. So it is not here. And then you have to always look for some duct differentiation. Okay. So this duct differentiation tells you that this might probably be a case of ecrine apocrine differentiation tumor. And if you see the epidermis, it shows you the characteristic means originate from the lower edge of the epidermis. See here, the left side, this is squamous epithelium. See the morphology of those cells, and then see the morphology of these cells. So the name is because the poroma is originating from the poroid cells, which opens up into the epidermis, right? So this junction is telling you that this tumor is a tumor of poroid cells. And this is a characteristic seal out of poroma. The down-growing tongues of tumor cells into the dermis that are originating from the epidermis, the lower edge of epidermis. So yes, this is poroma.
But poroma is basically comprising of purely basaloid cells only, na?
Basaloid looking cells, right? Poroid cells, you can say, rather than saying the basophilic cells,
Yeah,
because of.
To differentiate, can you differentiate?
What are the differentiation between poroid cells and basaloid?
Yeah. Please elaborate that, Dr. Rupesh.
See, when we if you go for the nuclear morphology, their overall round shape and everything, they looks basaloid cell. But if you go on high power, the difference of the what to say basaloid cells of basal cell carcinoma and the so-called basaloid cell, this poroma, you see the intercellular junctions. That tells you that this is have some relation to the overlying the squamous cells of epidermis. Okay, and yes, in all adnexal type of tumor, you need to seek for the duct formation. If you see the duct formation somewhere, you have to you have to start thinking in line of some adnexal tumor. That I was showing you, na, the transition between the poroid cells and the squamoid cells. See here, the intercellular junctions.
Yeah, here, clear. Correct.
Right. This you don't expect in basal carcinoma, basal cell carcinoma.
Right.
4 or 5 years back, I sent such kind of thing for slide review. I thought it's kind of malignancy.
Because of those tongue-like projections into the dermis.
I thought it's some kind of malignancy I'm missing. I was thinking of poroma, but I was thinking that I may be wrong. So this slide is really contributed to many of pathologists like us, because we get to see few adnexal tumor. Thank you, Dr. Rupesh and Dr. Vinita, for that.
Whenever you have doubt, always take an opinion from our colleague.
Yeah. I think we have finished it, Dr. Rupesh.
Yes, that case is finished. The next case is a 52-year female having the ulcerated nodular mass over right leg. Okay, the clinical history itself tells you that it might be a malignant tumor. Okay, ulceronodular mass over the right leg. Now, to follow the rules, see for the epidermal attachment. So yes, it is having epidermal attachment. And if you are still, you have the previous case still in your mind, So it looks like that, right?
Yeah.
I am just showing the juncture of the tumor and the overlying epidermis. Okay. And the tumor going downwards, it is still showing the same features. That is intercellular junctions, what we get in the squamous cells.
Even the cells look the same.
It is showing the skin ulcerations. Now we will see the shouldering or some seal out, if we can say. Here you cannot see the base of tumor. I am just showing you the periphery of tumor. Okay, it is looking lobular. So let us go on the higher power. See now, this is a necrosis, right? The apoptotic debris tells you okay, this is necrosis and not the secretion.
Nuclear dust or nuclear debris.
Yes, it is small duct. Okay, I just coincidentally got the duct, so I am highlighting it. It is a duct. So duct differentiation been confirmed. Again, one more duct. Okay, so that means we are dealing with some ecran apocrine tumor. But see again, even in this focus, you can see many mitosis. Okay, this one, this one, this one. So if I can highlight that many focus, that many mitosis in single focus, it should worry us. Are we dealing with some malignant tumor? I think it is sure now it is malignant tumor. I showed you necrosis. I showed you mitosis.
Shit, not able to find it. Oof, where is it?
Okay, and then the tumor is ulcerating the surface and it is originating from the overlying dermis. Okay, the nuclear atypia is also evident here, right? You don't expect this in any benign tumor.
Not able to see.
There are few large.
See the nuclear pleomorphism. Okay, these are not monotonous cells. Just compare with the previous slides.
Yeah. See.
Okay, this is mitosis. This is definitely atypical mitosis. This is nuclear pleomorphism. Okay, see these nucleus and see these nucleus.
Lobulated margins, nuclei.
Definitely, there is nuclear pleomorphism. So fine. So at least for the sake, one can label this is malignant adnexal tumor. Now, if you are interested, you can label this as some specific differentiation. So what you can label this now?
Porocarcinoma?
Porocarcinoma.
Yes, it is porocarcinoma. The other features of poroma are there, and then this is a carcinoma. So this is porocarcinoma.
Is it extending into subcutaneous tissue?
Actually, this tumor was received piecemeal. So you can just imagine the lower edge. See, this is open, right? This tumor was received piecemeal. So some adnexal tumor, if you are receiving piecemeal, that means it was difficult to get in toto. That means it might be a carcinoma.
Yeah, because it infiltrated into the tissue. Oh.
Okay.
It was difficult to enucleate completely.
So this case was just to tell you the features which should tell you that this has to be a malignant tumor. The necrosis with apoptosis debris, nuclear pleomorphism, atypical mitosis, and then the infiltrating nature of the tumor.
Nice one. Very nice one.
Okay, the next case is swelling on the back in a young female since 4 months. So just go with the rules. See for the epidermal attachment. So yes, it is attached to the epidermis. Okay. Now, if you see a very good transition, this is epidermis, and then it is getting transitioned into some glandular thing, right?
Clear gap.
See this transition. Okay. Now I am going on scanner view again to show the seal out of this tumor. So this is epidermis, and then the papillary kind of invaginations of the tumor within the dermis. Okay. See the papillae. This is a very characteristic, what to say, seal out of any adnexal tumor. I think this much should tell you the diagnosis. The epidermal attachment, papillary invaginations of tumor within the dermis.
Papillary hydradenomas.
Sorry?
Papillary hydradenomas.
Okay. Now see the dual cell population, and the papillary core is filled with plasma cells. Mixed cells, but plasma cells are prominent. Can you see the double layer lining?
Dual cell population is classical of
Papilliferum.
Siringo. Yes.
Yes.
Right.
Very classical.
So, as the name suggests, syringocystadenoma papilliferum is like a arising at the level of acrosyringium, right? That's why this characteristic finding of inward invaginations from the overlying epidermis. So that means this tumor is recapitulating the acrosyringium. And as the morphology is papillary, this tumor is named as syringocystadenoma papilliferum. I am just highlighting the two cell population, double layer population. And again, these apocrine snouts tell you that this is a tumor of apocrine differentiation.
Yes. Very
These
nice.
apocrine snouts. Okay.
It reminds me of some salivary gland tumor. Anybody can tell? Very classical.
A bit fast, madam.
It's Warden's tumor. Double layer of this and the population. Right. Double layer. Warden's tumor. Anyway, you two kind of cells. Two layers of cells. Columnar and cuboidal.
So, okay, I am done with my cases. So, any doubts?
Thank you very much, Dr. Rupesh and Dr. Anupama.
Thank you, Dr. Anupama. Fantastic presentation.
Our pleasure.
That were fantastic cases, ma'am.
Thank you.
Is it Lalit?
Yes, ma'am. Yes, sir.
Yeah, I could recognize your voice, which I cannot see you.
Typical slang.
But when Lalit has endorsed, it is as good as a good lecture.
Yes.
ललित तो छा गया है डीपी में. हर रोज एक नया ऐसा बम्पर ड्रॉ निकलता है उसका. Hello, Dr. Lalit, congratulations for your successive 3-4 presentations. And next in line, it will be fast. I invite Dr. Vaishali Kare. She is from Nashik to introduce Dr. Rupa Vishwanathan. Dr. Vaishali Kare, are you there?
Yes, sir.
Yeah, please.
Yes. Good evening, everybody. It's my pleasure to introduce. Hello. Hello.
You are audible. You carry on.
Yes, sir. My pleasure to introduce Dr. Rupa Vishwanathan, ma'am. She is MD Microbiology and DNB. She has done diploma in hospital health administration and RC Path from UK. She has worked as a lecturer for 3 years. She was HOD of microbiology section in Bombay Hospital. Now, currently, she is the chief microbiologist and director of Polylife Diagnostics and joint director Polylife Brain and Spine LLP. She has worked abroad for 4 years. Now, she is also having multi-talented tasks like she is infection control consultant for various prestigious hospitals in Bombay, like Sushruta Citizens Cooperative Hospital, Prince Ali Khan Hospital, SL Rahuja, Raheja Hospital, Hindu Sabha Neuro Unit, and she has many publications in her account in peer-reviewed national and international journals, and she has interest in tuberculosis and salmonella Their life is NABL accredited and approved for H1N1 testing. So really, we are now having our multi-talented and great academician, Dr. Rupa ma'am. So we welcome Rupa ma'am.
Thank you, Vaishali ma'am, for giving such a wonderful introduction. I think we still have a long way to go. I have miles to go before I sleep. So today's topic, I hope I'm audible and my presentation is visible. Is my presentation visible?
Yes, ma'am. Yes, ma'am.
Yeah. So today's topic is new generation sequencing. Now, as the name suggests, this pandemic, we have seen that RT-PCR has become a household name. Everybody is talking about RT-PCR. Even the common man is talking about RT-PCR, doing RT-PCR for COVID. So we've realized that the importance of molecular diagnostic has gained immense importance in this period. And we have realized that it is here to stay and it is going to help us in many more diseases in future. Now, to understand what is a DNA and a genome, so there are many terminologies which are very common as far as molecular diagnostics is concerned. And let's get to the basic of this. Now, let me tell you that this is a topic wherein I am also learning. And I know that this is going to be the future for in coming years. This is what we are going to resort to. So the first thing that I would want all of us to understand, that we know that DNA is a molecule that carries a genetic information. It has got bases, that is adenine, thymine, cytosine, and guanine. And the order of these bases provide the instructions for assembling the essential building blocks of life. Now, a gene is a segment of the DNA that contains the instructions for one of these building blocks, such as a single protein, whereas a genome is a complete set of DNA instructions, which is including all of the person's genes. In humans, the genome consists of about 3 billion bases, and all humans share 99.9% of this genome. And the remainder, that is only 0.1% of it, is variable. That is what is unique for each one of us and makes us different from the other. But trust me, 0.1% of 3 billion is still 3 million bases. It is nothing to sneeze at. A spot in the genome that can differ between people, for example, where some people have an A and others have G, is known as a single nucleotide polymorphism, SNP, which is very unique for each person. The version of the single nucleotide polymorphism a person has is their genotype. So SNP becomes their genotype, and these small genetic differences are part of what makes people unique. For example, now here, as you can see, each person has got the other sequence similar, but it is only just a single nucleotide which is different, and that is the one which is making this different. So single nucleotide polymorphism, that is the one which makes us unique. Human Genome Project is what has helped us to decode our DNA one base at a time. Human Genome Project, which began in 1990, so almost it took 3 decades for it to become a success, was a massive international effort, and it carried out by about 20 research centers and universities in 6 countries. The primary goal of this project was to determine the order of all the 3 billion bases in the entire human genome, and this process is known as sequencing. So it was like an assembling of a puzzle. So first, the scientists collected the biological samples, such as the saliva or the blood. Then they made lots of copies of the DNA in the sample and broke those copies into smaller overlapping pieces. The order of the bases or the sequence in each of those pieces were then determined by a series of chemical reactions. and the DNA broken into pieces or prior to sequencing, because these reactions can only be read into short DNA strands, typically less than 1000 bases. So they broke them down to 1000 bases. So this is what is known as the short-run whole genome sequencing, where a DNA sample was collected, many copies of the DNA were made, then these copies were broken down into smaller pieces, and these sequences were then arranged in correct order, and the complete genome was finally assembled. So this is how the whole genome sequencing was done. The next challenge was to assemble these pieces of puzzle into correct order, and they had some overlapping sequences from each piece as a guide. This was a very difficult computational problem, which especially for a genome which contained about 3 billion bases. So scientists knew this problem would be even more complicated in humans because of the human genome containing many repetitive sequences. For example, patterns like AGA, GA, GA, or TTTTT. So using these overlaps to guide a reconstruction of the genome is especially challenging in these types of regions. Imagine a puzzle in which many of the pieces are identically shaped. Then it would take longer time to put them back into their original positions. Another major goal of the project was to determine how many genes we actually have in our genome. Previous estimates ranged widely, with some scientists believing that there might be about 1 lakh genes. The Human Genome Project, however, found that in fact the humans have only 20,000 to 25,000 genes, which is the current estimate. This is to the lower end of that range. This number was quite a surprise to many scientists, because many organisms such as rice and water fleas actually have many more genes than we do. This was an important lesson for genetics. The complexity of an organism is not necessarily correlated with how many genes it has. So the Human Genome Project made it possible to ask and address new types of scientific questions. One example of such an important question is determining which single nucleotide polymorphisms increase or decrease in a given disease. Before the Human Genome Project, if scientists wanted to answer this type of question, they could only realistically focus on few small regions of the genome at a time. Now it would theoretically be possible to sequence many people with or without a disease and systematically test each base in that genome, asking, is one version of a SNF and SNP more common in people who have the disease? This type of study design is known as the Genome-Wide Association Study, GWAS. One of the important considerations for GWAS is cost efficiency, as sequencing the entire genome is still far too expensive to perform on large number of people. Therefore, scientists started using cheaper approach, selecting hundreds of thousands of known SNPs ahead of time and testing each individual's genotype at only those SNPs. So this is how they did. That the DNA was collected from the cases, that is from the patients, and they also collected from the controls, that is healthy individuals. Then they figured out the genotypes of the cases and the controls at SNP, which were determined, and as you can see that in the cases they found these variations, whereas in the normal this was what they found. So on the basis of that, the SNPs for the cases were determined. So scientists had previously been fairly successful at determining the genes that cause many rare and severe diseases, such as cystic fibrosis and sickle cell anemia. For these types of diseases, often a single SNP with an extremely strong effect could be pinpointed. Though it's important to note that gene discovery does not immediately translate into the therapeutic drug development. It is only the first step of a long and a complex process. It seemed natural to hope that GWS could prove similarly effective at determining the genetic basis for more common diseases such as heart disease, diabetes, inflammatory bowel disease, and schizophrenia. In the first years of GWS, however, it became apparent that matters would not be so simple. The findings suggested that a very large number of genes for some traits, easily into hundreds or perhaps even thousands, might have effects on a given disease. Moreover, these effects tended to be very small for each SNP. For example, a given SFP that affects the risk for obesity is usually associated with gaining of only a fraction of a pound. This conceptual discovery has been an important advance in our understanding of human biology. In the context of the drug development, this finding means that targeting a single gene with a drug may not cure all the people with a particular disease. Scientists are working to use information gained from GWS to develop and improve the therapeutic treatments. So where are we now with regards to GBS? Fast forward to 16 years from the completion of the Human Genome Project, the genomics have moved at a speed no one could have predicted. In recent years, one of the most significant developments in human genetics has been a resource called as the UK Biobank. This is a massive data set consisting of a genotype information which can be used for GWS from about 5 lakh human volunteers. Each participant also provides a veritable treasure trove of health data ranging from basic information such as a height and a weight to dietary questionnaires and disease status. This resource has revolutionized genomics not only because of the huge sample size and detailed medical information, but also because the data is freely accessible to any scientist who wants to apply it to use it. As a result, the genetic analysis of the UK Biobank data has essentially been crowdsourced to scientists all over the world. The impact of this is clear from the numbers. Since UK Biobank's initial release is 2015, almost 600 papers have been analyzed and countless new studies are on the way. Modern genomics is a triumph of the collaborative science and shows how much there is to gain with large-scale collective projects. 18 years ago, we didn't even have the complete human genome sequence. Now we have a publicly available resource of 5 lakh genomes on top of the millions of other people from whom genetic information has been collected for other studies. And GWAS is only one example of the type of research enabled by the Human Genome Project. There are countless other scientific fields that have sprung up in its wake. To name just a few other ongoing efforts, researchers have developed tests for genetic diseases, created a large catalog of genetic abnormalities which have been observed in many different types of cancers, studied the DNA of ancient hominids to better understand the human evolution, and developed ever-improving and ever-cheaper sequencing methods for a great example of human genetics directly contributing to therapeutic development. All of these endeavors have helped us to understand human biology better and have improved the medical research. The Human Genome Project set into motion genomic research on a scale that would have been hard to imagine in 2001, and the field shows no sign of slowing down anytime soon. Hence, it is the future. So let's come to next generation sequencing. Next generation sequencing is a powerful platform that has enabled the sequencing of thousands to millions of DNA molecules simultaneously. Next generation sequencing is also known as a high throughput sequencing, which is catch-all term used to describe a number of different modern sequencing technologies. The high demand for low-cost sequencing has driven the development of high throughput sequencing, which produce thousands or millions of sequences at once. They are intended to lower the cost of the DNA sequence beyond what is possible with standard dye terminator methods. Thus, these recent technologies allow us to sequence DNA and RNA much more quickly and cheaply than previously used Sanger sequencing, and as such have revolutionized the study of genomics and molecular biology. Now, there are different generations of sequencing. There is a first generation sequencing, second generation sequencing, third and fourth. First generation is Sanger sequencing, which was present almost 2-3 decades back. Now what we have is a second generation sequencing, that is pyrosequencing, sequencing by reversible terminator chemistry, sequencing by ligation. Third generation sequencing includes single molecule fluorescence sequencing, single molecule real-time sequencing, semiconductor sequencing, nanopore sequencing. Fourth generation sequencing is aimed at conducting the genomic analysis directly in the cell. No need to extract the DNA. Directly the cell is put in and we'll get the result. This is what is in the pipeline. So now, what does all this involve? What does new generation sequencing involve? First of all, First of all, the DNA is
नाही
fragmented
राहुल
and the
आला की मग
library
त्यातले
is prepared.
अण्णाला मी जाऊ दिलं पाहिजे ना नसतं नाही
Can I
तो
request everyone to be on mute, please? So the first thing that happens is a DNA fragmentation and a library is prepared of this. Okay. Then the probe is added to these DNA so that the capturing of that particular DNA sequence is done, which is either streptovidin or biotin probed. Then it is taken into a sequencing mechanism and the data is analyzed. So these are the basic steps of new generation sequencing. Now, this is a Link's Therapeutics massively parallel signature sequencing, which was a first generation sequencing, where the genomic DNA was cut into fragments. The linkers were put into it, and these linkers were then put into the library. They were flown through the cell, and the sequencing was subsequently done, and then these images were checked for. So it was considered the first of the next generation sequencing technologies. It was developed in 1992 and it is an ultra high throughput sequencing technology. When applied to an expression profile, it reveals almost every transcript in the sample and provides very accurate expression level. It was based on Beard's method and it used a complex approach of adapted ligation followed by adapted coding, reading the sequence in increments of 4 nucleotides. And this made it susceptible to sequence-specific bias or loss of specific sequences. However, the essential properties of the MPSS output were typical of later next-generation data types, including hundreds of thousands of short DNA sequences. In case of MPSS, these were typically used for sequencing cDNA for measurements of gene expression levels. I know it is very high level, but I'm also trying to understand it. Now, there is something known as a polyny sequencing, which was a second generation sequencing, where the genome, the DNA was fragmented. Then the universal, there were linkers to which the universal sequences were put in. The emulsion was done by PCR and the enrichment was done by these tagged primers. And then the cycles of sequencing and 4-color imaging was done. It was found to be an inexpensive but very highly accurate multiplex sequencing technique that could be used to read millions of immobilized DNA sequences in parallel. This technique was developed by Dr. George Church in Harvard Medical College. It combined an in vitro paired tag library with emulsion PCR, an automated microscope, and a ligation-based sequencing chemistry to sequence an E. coli genome at an accuracy of more than 99.99%. and a cost approximately 1/10 of that of Sanger sequencing. Pyrosequencing is something which we are using now more often. Here what happens is that luciferase is used for its identification. So a parallelized version of pyrosequencing was developed by 454 Life Sciences, which has been now acquired by Roche Diagnostics. The method amplifies the DNA inside water droplets in an oil solution, with each droplet containing a single DNA template, which is attached to a single primer-coated bead that can then form a clonal colony. The sequencing machine contains many picoliter volume wells, each containing a single bead and sequencing enzymes. Pyrosequencing, as I mentioned before, uses luciferase to generate the light for detection of the individual nucleotides added to the nascent DNA, and the combined data are used to generate sequence readouts. This technology provides intermediate read length and price per base compared to Sanger sequencing on one end and Solexa and Solid on the other. Illumina, that is the one which is now commonly used, Solexa sequencing, where there is a library preparation. Then the DNA which is fragmented is grown into clusters and the sequencing is done. And the imaging gives us the answer as to what sequencing it is. So Solexa developed a sequencing technology which is based on dye terminators. In this method, the DNA molecule are first attached to primers on a slide and amplified. This is known as bridge amplification. Unlike pyrosequencing, the DNA can only be extended one nucleotide at a time. A camera takes images of the fluorescently labeled nucleotide, then the dye along with the terminal 3 blocker is chemically removed from the DNA allowing the next cycle to commence. So this is how it takes place. Okay. The technology for sequencing used in AB solid sequencing is oligonucleotide ligation and detection. In this, a pool of all possible oligonucleotides of fixed length are labeled according to the sequence position. This sequencing results to the sequences of quantities and the lengths comparable to Illumine sequencing. Next, there is something known as a DNA nanoball sequencing, where here the isolated DNA fragments become balls. Okay, they are circularized. So that's why it is known as the DNA nanoball sequencing. It is high throughput sequencing technology that is used to determine the entire genomic sequence of an organism. The method uses rolling circle replication to amplify fragments of genomic DNA molecules. This DNA sequence allows large number of DNA nanoballs to be sequenced per run and at low reagent cost compared to other next generation sequencing platforms. However, only short sequence of the DNAs are determined from each DNA nanoball, which makes mapping the short reads to a reference genome very difficult. This technology has been used for multiple genome sequencing projects and is scheduled to be used for more. Helioscope single molecule sequencing uses DNA fragments with added poly-A tail adapters which are attached to the flow cell surface. The next steps involve extension-based sequencing with cyclic washes of the flow cell with fluorescently labeled nucleotides. The readers are performed by helioscope sequencer. The reads are short, up to 55 bases per run, but recent improvement of the methodology allows more accurate reads of homopolymers and RNA sequences. So the single molecule SMRT sequencing, here we are using the fluorescent tagged nucleotides which approach the detection zone. The nucleotides are then given a fluorescent signal which will lead to DNA polymerization with a fragment are then read. SMRT sequencing is based on sequencing by synthesis approach. The DNA is synthesized so-called zero-mode wave guides, small well-like containers with the capturing tools located at the bottom of the well. The sequencing is performed with the use of unmodified polymerase and is via fluorescently labeled nucleotides flowing freely in the solution. The wells are constructed in a way that only the fluorescence occurring by the bottom of the well is detected. The fluorescent label is detached from the nucleotide at its incorporation into the DNA strand, leaving an unmodified DNA strand. The SMTR technology allows the detection of the nucleotide modifications. This happens through the observation of the polymerase kinase. This approach allows us to read up to 1,000 nucleotides. So here what happens, here in a single molecule RNA motion based real time sequencing, the RNA is converted into DNA. So you are using the base as the RNA, and here again the beads are used where the reading is further done. So this method is based on a RNA polymerase which is attached to a polystyrene bead with distal end of sequence DNA is attached to another bead with both beads being placed in optical traps. The RNAP motion during the transcription brings the beads in closer and their relative distance changes, which can then be recorded at a single nucleotide resolution. The sequence is deduced based on the 4 readouts with lower concentration of each of the 4 nucleotide types. So what we have in short with new generation sequencing is that you have fragmented DNA input, then there is a repair of the ends, then there is a DA tailing, then the adapter ligation, then the site selection, amplification, and then the final sequencing. There are 2 libraries which have been constructed, the DNA library as well as the RNA library. It is against this that the matching takes place. So the next generation sequencing requires a library preparation first of all. There is a clonal amplification and then the cyclic array sequencing, which will either undergo an emulsion PCR, which would be then leading to a pyrosequencing if we are using luciferase, and it is if by ligation, then we are doing solid platform, that is sequencing by ligation. If there is a bridge PCR that is being done for this fragmentation, the sequencing is done by synthesis, where DNA polymerase is used. So next generation sequencing is increasingly being applied to clinical testing. This practice is predicted to grow, especially in neurology clinics, because many of the neural patients have monogenetic causes for their diagnostic odyssey. The cost of sequencing has been steadily decreasing, but the cost of the DNA sequence is only a minor part of the total cost of the treatment of such patients. New generation sequencing is also has got a major role as far as cancer management is concerned. So here again, what we have shown is that the sample is collected, the genome is taken out, the DNA fragments are formed. These are either amplified. The clonal amplification is done either by emulsion PCR or by bridge PCR. In emulsion PCR, if we are using a luciferase, then we are dealing with pyrosequencing, and if we are using a ligase, then we are doing sequencing by ligation. And if we are using DNA polymerase, then we are doing sequencing by synthesis. The same thing that I had discussed before. Now, as we had discussed before, there is a first generation sequencing, that is Sanger sequencing, and a second generation sequencing. The difference between the two is that Sanger sequencing is limited to determining the order of only one fragment of the DNA per reaction. So it can go up to a maximum length of only 700 bases. Whereas a new generation platform, that is from second generation onwards, we can sequence billions of DNA fragments in parallel in one reaction. So this gives us an enormous amounts of data. Whole genome sequencing or whole exome sequencing has also shown promise in the identification of genetic causes. Both WGS and WES have incomplete coverage and produce a large number of rare variants of unknown importance. So there is an ethical dilemma which has been created by unexpected findings in genes unrelated to initial sequencing indication. So many times when they are doing genetic testing, there are certain unrequired information which is also being circulated. And most of the times it puts us into a confusion. So targeted panel NGS is the answer. And it starts with the capture of a set of disease-focused genes, which is followed by massive parallel sequencing. So for many genetically heterogeneous neurological disorders, a genetic panel that is disease-focused yet inclusive of a large genetic information can be defined to reduce the cost, increase the turnaround, and optimize the performance. Targeted panel NGS is currently the preferred first-tier approach because it provides a reliable clinical application while eliminating unexpected ethical dilemmas. Targeted panel NGS is leading to a paradigm shift in the diagnosis of many neurological diseases, enabling individualized precision medicine. 3 NGS approaches are currently available: whole genome sequencing, whole exome sequencing. Exome is just a part of the genome, and targeted panel sequencing. Clinicians, patients, and insurance providers are wrestling to provide genetic testing recommendations. The importance of the laboratory geneticists and the clinician working together in designing, implementing, and updating clinical genetic testing of paramount importance today. Currently, for many categories of neurological diseases, targeted panels are the most efficacious choice, and emerging evidence indicates that application of targeted NGS can improve the quality of the patient care and can reduce healthcare expenses. This is whole genome sequence where everything is fragmented out and everything is captured. Whereas in a whole exome sequence, only a part of the genome is captured. Whereas in targeted panel sequencing, just the targets are captured. Okay. So a typical workflow of the NGS is, as we have discussed, there would be a DNA fragmentation, nucleic acid library preparation, and then next generation, and the sequencing which is matched with this library. So the same thing which is discussed in length here. So sample is isolated. There is an enrichment of the target. The library is constructed. The new generation sequencing is run, and the data is analyzed, and we get the results. So the advantages of this is multiplexing. specific enrichment. This leads to high sensitivity. The hands-on time is reduced considerably, and actionable insights are produced. Integrated bioinformatic pipeline is what it will lead to. At the moment, pyrosequencing has been of immense help for detection of extensive drug-resistant Mycobacterium tuberculosis. It has been found to be a rapid, effective sequencing method to diagnose drug-resistant tuberculosis. It has been also found to be very, very effective in diagnosis of CNS tuberculosis. CNS tuberculosis is so common in India, and we really fall into trouble because CSF AFB is negative most of the times. In this particular study also, CSF AFB was negative. Culture is also very difficult, and gene expert has been able to, or genetic PCR has been able to extract only 50% of the times the diagnosis. In this particular study, they found that pyrosequencing has been able to detect in all the 100% of the cases TB meningitis. What these new generation sequencing can help us is to find out the mutations, whether it is deletions or insertions. And this has been definitely found out in the codons of RPO. And these codon numbers are 531, 526. So what happens is that in tuberculosis diagnosis, many times LPA or gene expert, we are looking for specific mutations. There are other mutations which are not looked for. These can be answered by the new generation sequencing, where the mutations on these codons can be also detected, and the appropriate management of these patients can be done. So what is the future is that we have to remember that each individual has got very unique outcome. So NGS will help us to have what is known as personalized medicines. And these genomics will help us to have tailored treatment. So every individual will have a tailored treatment which is meant only for that particular individual. And in this way, we can effectively prevent, diagnose, and treat critical illness with more precision. Today, COVID has COVID patients. Some of the patients have really, gone treatment of such patients have gone haywire. Some of the patients have not been able to be pulled out. There are other patients who have just recovered very easily. So this is because each individual has got very unique outcome, and that is what exactly NGS will have in future for us. These are the references. Thank you.
And body reaction is very. दाताचं तो सांगतो ना अनु किती कसली पेन म्हणतो तो त्याला काय ते म्हणतो शब्द हा दात खरा केलेला असं दुखतं बोलतात दात.
Panelists, please are requested to mute their microphones. Their home conversations are getting recorded and interfering. Please, requesting.
Thank you, Dr. Rupa, for this wonderful talk. The floor is open for discussion now. Any queries, any questions? You can direct it to Dr. Rupa.
Can you elaborate on any laboratories which are really involved in this kind of research in India, whether we have it in Mumbai, and how do we compare with the international standards?
So we are definitely, that's a very interesting question, and definitely there are many people who are working on it. There are many institutions who are having the provisions for doing the NGS, and they are doing tremendous research as far as cancer is concerned. So things are definitely moving at great scales.
Okay, that's really nice. Swaroop, this is Meena here. Swaroop.
Yeah. Hi.
Yeah,
Yeah. I'm
Swaroop, hi.
here.
Yeah, Swaroop, last week or this week, we had one request from one doctor in the TPA group for for a friend's daughter who's 2-year-old and suffering from a very rare disorder where some kind of gene therapy is going to be instituted, which is going to cost something like 16 crores. You remember that message?
Yeah. Yes.
I don't exactly remember the name of the therapy, but gene therapy, and it's going to be so exorbitantly, costly. So I just want to ask Dr. Rupa, because I don't think we still have that kind of therapy. Obviously, it must be abroad. It must not be in India. I think it was SCA, some kind of a spinal disorder where, the muscles are going to be very weak. So Dr. Rupa, can you please elaborate on, the treatment costs and whether gene therapy is really being practiced in India?
So definitely there are a lot of studies being, are you talking about degeneration of the spine kind of thing?
Actually, I really cannot remember if I trace back the conversation, but it's a 2-year-old. She's a very small, tiny girl, and she's having some spinal disorder, neurological disorder. I really cannot recall the exact details.
So
And
what can be done is that like I mentioned in my presentation, so these people are working on the single nucleotide polymorphism for various diseases, and they are figuring out as to where the polymorphism is happening, and then they are targeting the therapy to that particular that particular gene at that particular genetic level. So the work is happening in this direction, and definitely it will not be too long before we see a major success in this direction.
all right, I really hope so, because as what they said, the cost is going to be so exorbitant, 16
It is
crores.
going to be, but as far as the new generation sequencing is concerned, the rates have come down drastically. Before it was much more higher. People had to spend lots of money, but now the cost of testing has come down drastically.
Okay, that's great. Let's
But
hope for a better.
treatment will take time, I guess, because diagnosis is just a part of it. The treatment will take a little longer, and it might be still costly for at least a decade or so.
Right. Okay, thank you so much.
Any other question? So, thank you, Dr. Rupa.
Thank you, sir.
A good thing we did not take microbiology because it is so difficult, even difficult to understand. Okay, you are given a lecture means you are secret. So, I hope you have all enjoyed this first endeavor of our online webinar. Though there is no eye contact and interaction, still we could manage. 10th, another episode of this webinar in the morning. Dr. Parag Dharap, Dr. Kunal Sehgal, Dr. Sonal Bangde are one of the, and yes, Dr. Supriya Datta. So a battery of highly intelligent people is reserved for Sunday. Actually, we were planning on one day, but it would have been too taxing. So it's good thing that we separated these seminars. Similarly, there will be in February also, and we wish to hold one online general body because that is also a pending matter for our purpose. The good thing with that, we have got 12A from income tax. So there are some good news, but year was not good for our practical purpose. That is, we could not hold conferences. And if things improve, yes, in March we'll meet together. With these words and with this note, thanking all the newcomers, new members. Our passion is we introduce all the newcomers and we welcome them with a flower. This time it is not possible. So I virtually congratulate all the 82 newcomers, and the strength was today something 250, though 300 registered. So it's good number, and hope we have very good number. Mr. Mehta, you are there?
Yes, sir. Yes,
Yeah.
sir.
Yeah. Thank you very much for all the efforts you have taken.
My pleasure, sir.
You are so soft spoken and
Thank you, sir.
gentle.
Thank you.
So I'm afraid that I have not bulldozed anything to you.
No,
So
sir. No, sir. No.
and we
Definitely not.
expect similar cooperation henceforth, because for state level to approach it is online webinar is a very easy way. And most important thing, to learn the how to change the name and how to add the MMC number. Don't ask on WhatsApp and don't ask to me, because I too am a very old person and new technology is not that simple. So I hope and we come for the next and Mr. Mehta, Dipin.
Yes, sir.
Uh, if any charges are to be paid, I don't mind.
No, no, sir. No.
We will have a platform of 500, so all should be visible on
Yes,
video.
yes, definitely. So we will buy the premium subscription by tomorrow.
And I am
So
sure
we'll share the link by tomorrow evening.
for next CME there will be still very good attendance, because it is Sunday, and 2-3 speakers from the list are very celebrated speakers, and so many new members have joined. So many our old members have renewed. Some old members are renewing. So definitely it will be a 300 plus figure. Sure. With these words, we close. 8 o'clock is there. Thank you very much and good night. Yeah. I know.
No one wants to leave.
No one wants to give. because hardly any patient comes.
Want to see the participants, so no one wants to leave.
Actually, we should have in Corona period. We should have this more. Actually, at least we could have shared our grief that nothing is happening. But all other faculties are now experiencing what is the slack. The hospitals are not running properly, and now they are finding how we have survived till this day. It is very difficult. The old people are complaining that it is difficult to survive. I am worried how the newcomers, and especially in last 2 or 3 years, those have started their practice with a huge investment, and they see that the whole 1 year goes without any earning. It's very painful. Let us hope for a better tomorrow. चलो अभी बंद करो. Thank you. Good night.
Okay, sir. Thank you. Bye.
Yeah.
Bye.
Mr. Aditya, you can take over, please.
Yes, sir.
Thank you.
Thank you, guys. Thank you all.
Yeah. Good night. You have taken the last photograph also, na?
Yes, yes.
Yeah, good.
I taken the screenshot.
Yeah.